Very good evening to all. This is Dr. Abhirami, your physiology faculty. Welcome all of you to this rapid revision session just before your INI-CET exams. So this is going to be a mind refreshing session for all of you. So we have started our sessions with basic subjects and ongoing to clinical subjects. We will have a rapid revision of all 20 subjects for you. And we are all connected in the, yes, hi, Dr. Vishwanath is there already on the chat box. Yeah, we're all connected in the chat box. Any queries, any doubts, please talk me in the chat box. So we will be communicating through the comment box there. Yes, very good evening, Dr. Vishwanath. So students are still joining. So let me start off this session with INI-CET Prepathon 2024 exams, physiology session with me, Dr. Abhirami, your physiology faculty. So usually I start all my classes with this beautiful image. I like this image a lot. Working hard and working smart. There's a lot of difference between hard working and smart working. See, can you see in this image two people who are working hard on top and look at that man who is working smart below? Yes, this is how you have to approach your exams. Till now, you would have done a lot of hard work for your exams, but that is not enough. Smart work. From now onwards, your last minute preparations should be a smart planned work. What is that kind of smart work that you can do? How I can help you with the smart and planned work that you can do. The one thing that I can tell you, yes, hello, doctor. Yes, still students are joining. Yes. So for those who have joined just now, I'll just give a small intro of what is happening here. We have just started the INI-CET Prepathon Physiology Rapid Revision session. So just now I have started the sessions. And let me give you examples or how would you go about doing this smart work. Just before we go exactly into the subject, let me tell you what is that smart work that you can do, especially just before your exams. When you have few weeks or few months before your exams, what kind of smart work that you can do? See, number one, high yield topics. Give more importance for high yield topics. Don't try to study everything that comes on your way. Yes, good evening, doctors. Yes, so many of you have joined in the session. Thank you so much. Very good evening to all of you. High yield topics. What is that high yield topic? How will you know which is the high yield topic for your exam? That is what the sessions of rapid revisions are going to help you. If I'm going to take 3 hours of physiology rapid revision session for you, so I will be covering all the high yield topics which are must read topics before you go for your exams. So high yield topics, give more importance and more time for this. Don't waste time reading everything that comes in your way, especially PYQs. The mantra to crack any entrance exam is previous year questions. If you are well versed with the previous year questions, definitely will be there on the list. And also keep in mind, since you have negative marking in your exams, if you make a mistake in a PYQ, a previously asked question, if you make a mistake, definitely you will be out of the list, because even any average preparing student will have a good hold of PYQs. So PYQs is a very important mantra for solving any entrance, especially competitive based exams like NEET or INI-CET. So high yield topics is one of the smart work that you can do. The other smart work that you can do, Hebb's rule. Number 2. What is Hebb's rule? Have you learned about Hebb's rule in neurophysiology? I'll tell you what is Hebb's rule. HEBBS. Hebb's rule is your brain is able to convert short-term memories into long-term memories. How do you do that? For example, if you are in love with someone, you love someone, you keep thinking of that person again and again. If the class is boring, you think of that person. If it is raining outside, you think of the person. You listen to a nice romantic song, you think of that person. Every time you think of that person, your brain is converting short-term memories of that person into long-term memories. You will never forget that person. If you had truly loved anyone, lifelong, you will never forget that person. That is because your hippocampus in the brain does this. You can do this to your subjects also. Can't we convert short-term memories of physiology into long-term memory? No need to remember lifelong. At least till your exams, you should be able to remember. How will you do that? Think of the subject again and again. Revise your subjects again and again. Every time you revise your subject, your brain, your synapses are releasing calcium ions and it is automatically converting short-term memories into long-term memories. So read one time, revise 3 times, at least 3 times. Minimum, I'm telling you, at least 3 times you have to revise your subjects. Only if you revise 3 times, your hippocampus will convert short-term memories into long-term memories. So keep on revising the subject, especially during the last 1 or 2 months of preparation. Very, very important that you revise the subject. Don't keep learning new things. It will never help you. Whatever you have learned till now, keep on revising the subject again and again. At least 3 times, definitely you have to revise. Only then you are helping your brain to convert short-term memories into long-term memories. So the other mantra to crack your competitive exams, revision. Revise again and again. Don't learn new things in the last moment. The third thing that you can do, practicing MCQs every day, especially during the last periods of preparation. Instead of learning whole lot of things, solve MCQs every day. Because if you have the habit of solving MCQs every day, reading a question, reading the 4 options and ruling out the distractors, clicking on the right option, submitting the right option, all this if you are able to do every day, it comes by practice. On the day of exam, definitely you'll have free hands in handling your online type of questions, or basically the computer or this clicking thing. All that is a practice only. So please solve questions every day. Definitely that will help you. The more number of questions you solve, more probability that you will definitely top the list. So it is not about how much I learn. It is about how many questions I have solved. So please spend 50% of your time for solving MCQs. Keep 50% of your time for reading and other 50% for solving MCQs. That will definitely help you. Yes, good evening. I can see so many messages in the box. Thank you so much. Good evening to all of you. Yes, so with this, an introduction to hard work and smart work, few tips I have given you just before your exams, 1 or 2 months just before your exams. How do you change your hard work to smart work? Try doing all this. Definitely you will get through. So over to the session as such. So how are we going to go about this physiology last minute revision session? First, what we'll do, I'll give you the important must read topics in each of the chapters in physiology, and then we'll discuss facts and important PYQs from these topics. To start with, physiology, general physiology and cell physiology. So first, let me tell you what are all the must read topics. Don't go to your exam without reading these topics. So I've given only selective topics, not all. So let's do that. And I have also given star rating for the topics. So if you see a 5-star on a topic, high yield, very high yield topic. So respectively 3-star or 2-star or 1-star means. So definitely all the topics that you are seeing on the screen are must read topics before you go for your exams. As far as general physiology and cell physiology is considered, homeostasis, very, very important topic, 5-star question, homeostasis. Fluid compartments, comparatively important topic. Transport mechanisms across the cell membrane. Intercellular connections. All these are must read topics from general physiology. As far as nerve physiology is considered, membrane potentials, high yield topic. You can put as many important as possible because every year we can get questions from membrane potential. Action potential, very, very high yield topic, 5-star question. Nerve fiber classification, again an important question. Muscle physiology, muscle excitation contraction coupling, again a very important topic. structure of muscle fibers, anatomy as well as the functional anatomy, tetanizing frequency and the formula, just the formula to calculate tetanizing frequency. Over to CVS, cardiovascular physiology, baroreceptors, very important topic, high yield topic, put as many important as possible, very important topic, BP regulation and baroreceptors. JVP, jugular venous pulse, exercise physiology, heart sounds, Poiseuille's formula, cardiac cycle, cardiac output, cardiac action potential. All these are high yield topics from CVS. Renal physiology, renal absorption and secretion, 5-star question. Again, put many important marks. Very important question. Definitely you will have questions from this part. ADH and SIADH, antidiuretic hormone. Glomerular filtration, GFR, again a high yield topic. Countercurrent mechanism, JG apparatus, juxtaglomerular apparatus, again a high yield topic. Respiratory physiology, pulmonary function tests, very important, especially the flow volume loop, very high yield topics. Almost every year you can get questions from this topic. Lung compliance, oxygen hemoglobin dissociation curve, lung volumes and capacities, hypoxia, high altitude, COPD, dead space. So all these are high yield topics, especially the starred ones, very important. Endocrine physiology, glucose transporters, hypothalamus, thyroid gland, growth hormone, second messenger system, prolactin, leptin, adrenal insufficiency. So comparatively you can see that there are no 5-star topics from endocrine physiology. GIT motility is very important. GIT hormones, peristalsis, there are questions from peristalsis. Gastric acid secretion, again a high yield topic. Iron absorption, cholera toxin mechanism. Neurophysiology, and you can see that there are no 5-star questions from neurophysiology as far as INI-CET is concerned, because if you go through the previous year papers, you will see neuroanatomy has been given lot of importance, but neurophysiology comparatively less questions are asked. But still, whenever there is a question from neurophysiology, you can find these topics: sensory receptors, cerebrum, the lobes of cerebrum, homunculus, pain physiology, visual pathway and its defects, synapse, cerebellum connections, basal ganglia, memory and taste pathway. So these are all the high yield topics or the must read topics. I've given only 6 or 7 topics from each chapter. So definitely you have to learn all these topics before you go for your INI-CET exams. Let's start our session with general physiology, general and cell physiology. Let's discuss all this from INI-CET point of view. What are all the important things just you have to understand before you go for your exams? Let's start with general physiology. Homeostasis. Yes, very good evening, doctors. So many of you in the chat box. Very good evening to all of you. Thank you for joining the session. Hope it will be a useful session for all of you. Yes, homeostasis. What is homeostasis? Maintenance of an internal environment inside your body. This is called homeostasis. What are the examples for homeostasis? How you maintain your body temperature, blood pressure, blood pH, acids, base, how all this is maintained inside the body. That is called homeostasis. What are the control systems which will maintain your homeostasis? Who is maintaining all this homeostasis? The control systems. What are the control systems? We have feedback control system and feed forward control system. What is feedback control system? When you have a stimulus And when there is a response, the stimulus increases the response and response increases the stimulus. One is enhancing the effect of the other. This is called a feedback control system, and especially a positive feedback system. When stimulus and the response are enhancing each other, one is increasing the effect of the other, that we call it as a positive feedback system. Then what is a negative feedback system? Exactly the other way. When you have a stimulus and a response, when stimulus and the response act in opposite directions. For example, when there is a fall in T3, T4 levels, thyroid hormone levels are decreasing. What change would you expect in the response of TSH? TSH increases. Yes, TSH level increases. When T3, T4 levels are decreasing, as a negative feedback system, TSH is increasing. So this is an example for negative feedback. So we have two types of feedback system, positive feedback and negative feedback. What are the examples for positive feedback and negative feedback? Then we'll come back to feed forward. Positive feedback and negative feedback system. Positive feedback, the examples are, the mnemonic is CLAPS. C L A P S. C for calcium induced calcium release. This happens in your heart fibers, cardiac muscles. And C for clotting mechanism. L for LH surge, luteinizing hormone LH surge. L for lactation reflex or the milk ejection reflex, which is that hormone which plays an important role in milk ejection reflex. Oxytocin or prolactin? Yes, anybody can answer. Which is the hormone which plays an important role in milk ejection reflex? Oxytocin or prolactin? Yes, it is oxytocin. Do not confuse oxytocin with prolactin, because prolactin produces lactation. So prolactin is like a production unit. It will only produce milk. It can only produce lactation. Production unit. But who is the marketing unit who will go and eject milk to the baby? Oxytocin. So milk production, prolactin, but milk ejection, who will give the milk to the baby? Who will eject the milk to the baby? It is oxytocin. So milk ejection reflex because of oxytocin. Yes, very good, Dr. Vishwanath. Oxytocin. Action potential. Parturition reflex at the time of labor, delivery of the baby. Parturition reflex or the Ferguson's reflex. And shock. What happens when body is in shock? Heart is not pumping, cardiac output decreases. When cardiac output decreases, blood pressure decreases. When blood pressure decreases, venous return decreases, and again cardiac output decreases. If you don't intervene, the patient will die from shock. So one is enhancing the effect of the other. So CLAPS. All these are examples for positive feedback control system. What about negative feedback control system? Examples for negative feedback system: all hormones except LH and oxytocin, because LH and oxytocin follows positive feedback system. BP regulation by baroreceptors. Whenever there is an increase in BP, baroreceptors would decrease the blood pressure. This is the negative feedback control system. So that was about the feedback control system. Positive feedback, negative feedback. What about calculating efficiency of a negative feedback system? How will you calculate if any feedback system is effectively functioning or not? You can calculate gain of the system. What is gain of the system? Gain is equal to correction divided by error. This is the formula to calculate gain. How would you easily remember this formula? I usually get confused with this correction and error. See, we would have done lot of errors in our life. Put all the errors down. Out of all the errors, how much ever you have corrected is a gain for you. Of all your errors, how much ever correction you have done, this is a gain for you. So gain is equal to correction by error. Usually, gain is given in terms of negative value because it is calculated for a negative feedback system. This is how we calculate gain of the system, correction divided by error. There is one system which has infinity gain. Infinite gain. How do you have infinite gain? Infinite means so much of gain, infinity. If you have so much of gain, it means the system has not left any error at all. Error is zero. So when error becomes zero, there is no error at all. The system is 100% effectively functioning. It has not left any error. If error is equal to 0, anything divided by 0. What is the value? If you divide any number by 0, you will get infinity. So when do you get gain as infinity? When error of the system is 0. Which system has 0 error? When kidneys are controlling blood pressure. Renal regulation of BP. Infinite gain can be seen when kidneys are regulating blood pressure. Renal regulation of blood pressure and blood volume. When kidneys are handling blood pressure, they will leave no error. Error of the system is 0. When error is 0, infinity is the gain. So that was a question, which is that one system which has infinite gain, renal regulation of blood pressure. Over to feed forward control system. So till now we had learnt about feedback control system. Now over to feed forward. What is feed forward? When there is no actual stimulus, even if there is no actual stimulus, sometimes you can get a response. This is called feed forward. Without an actual stimulus, how will you get a response? We can get sometimes. Example, anticipatory tachycardia. When you run on a treadmill, your heart rate can increase. But sometimes, even before getting onto the treadmill, your heart rate can increase. When will this happen? You take your grandparents near the treadmill, you make them stand near the treadmill and you tell them, for the next 1 hour, you have to run on full speed on the treadmill. Just thinking about that itself, their heart rate will increase. So even before stepping on to the treadmill, their heart rate can increase. So that is called anticipatory tachycardia. Even before running on the treadmill, their heart rate is increasing. The other example for feed forward control system, anticipatory cephalic phase of gastric acid secretion. Just if I show you a video of making of a nice cheese pizza with some nice toppings and all that, your gastric acid secretions can increase. Or if I bring a nice chicken biryani plate nearby your nose and I show you the smell of that, just by looking at the delicious food or by getting the smell of the food itself, your secretions can increase. So all these are anticipatory cephalic phase of gastric acid secretion. Looking at the food or thinking about the food or smell of the food. It is not the food. Food is the actual stimulus. Even without eating the food, thinking or smell of the food itself, if it is increasing your gastric acid secretion, then it is anticipatory cephalic phase of gastric acid secretion. Yes, very good. Dr. Deepa, very good. Varun. Shivering mechanism. The third example, shivering mechanism by posterior hypothalamus. When you enter into a cold room, we shiver. Why do you shiver? Even before your body temperature could fall, when you enter into a cold room itself, your hypothalamus is telling you your body temperature is going to fall. So before that, I'll make you to shiver. When you shiver, what happens? All your muscles are contracting. When your muscles are contracting, heat is produced. See, that is how even before actually your body temperature could fall, when you enter into a cold environment itself, posterior hypothalamus causes shivering mechanism. Cerebellum, other example, motor correction by the cerebellum. The cerebellum, when you're just walking or running, you miss your steps. You don't actually fall. You're about to fall, but you don't fall. So what happens when you miss your steps, when you miss your balance itself, even before you could fall, your cerebellum will give you a motor correction. That's how Even if you miss your steps, you don't fall. Somehow the cerebellum gives you a correction and you come back to your position. So even before falling, your cerebellum is giving you a motor correction. So all these are examples where there is no actual stimulus, but still you can get a response. Feed forward control systems. So that was about the different types of control systems that are maintaining your homeostasis. So let me show you a repeat question that was asked in INI-CET 2020 examination. In a negative feedback, feedback gain of infinity is seen in which of the following? Yeah, just now we had discussed. Blood pressure control by the kidneys. Yes, when kidneys are regulating your pressure, blood pressure regulation by the kidneys. So that was about the first topic in general physiology, homeostasis. Transport across cell membrane. Yes, Dr. Med Psycho. Hypothermia. Yes, the other way can happen in hypothermia also. Transport across the cell membrane. Very important topic. Let's learn this topic of active transport, passive transport with a small example of, let's say there's a mountain. If this is a mountain and there is a person who wants to climb the mountain. Yes, there are a lot of students. So we'll say Dr. Vishwanath is there. Okay. So Dr. Vishwanath wants to climb this mountain. We are learning transport mechanisms now. If Dr. Vishwanath wants to climb this mountain, how will he climb this mountain? He has to go from low to high. He is going against the gradient. So this is against the concentration gradient. Does he need energy for this? Yes, definitely he needs energy. If you have to climb a mountain, you need energy. You need energy. You have to climb actively. So this is called active transport. So what is active transport? Transport against the gradient that requires energy. How will Vishwanath get his energy? What is his primary source of energy? You break your own ATP, get your own energy. This is called primary active transport. So what is his primary method of getting energy? ATP. So if you break your ATP, all ATPase, these are examples for primary active transport. Sodium potassium ATPase, hydrogen potassium ATPase pump, calcium ATPase, all these are examples for primary active transport. Whenever you break your ATP is example for primary active transport. What is secondary active transport? Secondary means now Vishwanath wants to climb the mountain, but he doesn't want to use his primary source of energy. He doesn't want to waste his ATP, but he wants to climb the mountain also. So what is he doing? Let's say there is his friend who is already climbing the mountain. See what Vishwanath is doing? He is just climbing on top of his friend and both of them are moving up now. But Vishwanath is not breaking his energy. He is not using his primary ATP, but he is using his friend's energy. Most of the time, the friend is sodium. So if any substance is utilizing energy from sodium, the friend, then it becomes secondary active transport. So if you are not breaking your own ATP, but still you are using your friend's energy, you are climbing on top of him and both of you are going, this becomes secondary active transport. What is example for secondary active transport? Most of the time it is along with sodium only. And here there are two types. If sodium and the substance are moving in same direction, then it becomes a symport. What are the examples for symport? Sodium glucose cotransporter, SGLT. Sodium iodide symporter, NIS. Sodium amino acid cotransporter. Basically, sodium and the substance moving in the same direction, all these are symporters. The other type of secondary active transport, antiporter. What is an antiport? If sodium and the substance are moving in opposite directions, then it becomes an antiport. Example, sodium calcium exchanger, sodium hydrogen exchanger. All these are antipode because they are exchanging. Sodium calcium exchanger, sodium hydrogen exchanger. So all these are antipode. So this is about active transport. Primary active transport, ATPase. Secondary active transport, two types, sympode and antipode. Next, let's learn about passive type of transport. What is passive transport? Passive transport is, now let's say Dr. Vishwanath is already on top of the mountain. He just wants to come down. How will he come down? He is coming along the gradient. Yes, Dr. Med Psycho, good. He is coming along the gradient. He is coming from up to down. So this is along the gradient, not against, along. Along the concentration gradient. So if you come along the concentration gradient, you don't need energy. He can just lie down there, he can roll and he can come down. So no need of energy. No energy is required. This is passive type of transport. Along the gradient does not require energy. What are the different types of passive transport? Simple diffusion. Simple diffusion. Example for simple diffusion, oxygen and carbon dioxide. The vital gases, oxygen and carbon dioxide, how are they transported across the membrane? Just by simple diffusion. You don't need any transporters for O2 and CO2. Just they can cross the membrane. Facilitated diffusion. Facilitated diffusion. What is facilitated diffusion? There is someone who will facilitate your transport. Let's say there is a bus on top and Vishwanath gets onto the bus and the bus is carrying him down. Bus is helping him. Bus is carrying him. So if there's a carrier protein which is carrying the substance, it is facilitated diffusion. But the problem here is a bus can hold only 50 people. If you are the 51st member on the queue, there's no place for you. So it will reach a T max. Once it reaches a T max means transport maximum. A bus can transport only 50 people. If you are the 51st member, there's no place for you. So once it reaches the T max and after that, bus cannot transport you. It will stop. It reaches a saturation. So Tmax and saturation kinetics are followed by facilitated diffusion. The other type of passive transport. Can you give examples for facilitated diffusion? Yes. What are the examples for facilitated diffusion? Can you give any transporter which will transport glucose? Multiple times asked question in your exam, which is an example for facilitated diffusion. SGLT is active transport, which is the other glucose transporter. Yes, nobody knows? Like SGLT, there's another glucose transporter. GLUT transporter, very good, GLUT, GLUT transporter. See, there's a difference between SGLT and GLUT. SGLT is sodium along with glucose. It is secondary active transport. But GLUT is just a facilitated diffusion transporter. It will carry just glucose. That's all. Not along with sodium, only glucose. The other example is UT, urea transporters. They are also examples for facilitated diffusion. GLUT transporter and urea transporter. The other type of passive transport is for water. Water uses osmosis. Osmosis is movement of water from its high concentration to its low concentration. But in osmosis, water can simply go across membranes or water can use water channels called aquaporins. So both can happen. It can just move across the membrane or it can use aquaporins. These are the different types of passive transport mechanisms. So that was about active and passive transport. Let's move on to a question based on this, which was asked in INI-CET May 2022 paper. Substances and the type of transport across the membrane are given below. Choose the correct combination. Actually, all are correct. Oxygen, simple diffusion. Yes, it is correct. Glucose, facilitated diffusion. Yes, that is right, because glucose can use GLUT. GLUT is a facilitated diffusion. Sodium, voltage gated channels. Yes, in action potential we will learn this. The depolarization phase of action potential is due to voltage gated sodium channels. So sodium can use voltage gated channels also. Sodium secondary active transport. Yes, sodium can use secondary active transport also, because we have SGLT for transporting sodium, which is a secondary active transport. Calcium active transport. Yes, calcium, we have calcium ATPases, which are active transport. So all are actually correct. So all of them are correct combination. Over to the other topic from general physiology, fluid compartments. Yes, Dr. Deepnayan, all are correct, all are correct. Yes. See, especially when you have questions like this, all are true except, all are false except. Please be very careful, dears. Don't make mistakes, silly mistakes like this when you have false except, true except, none of the above, A and B. Please think once again before you go for your answer, because if you make a mistake without knowing the answer for a question, that's okay. But if you make a mistake, a silly mistake especially, you only will not forgive yourself after your exams. So please don't do silly mistakes. How do you correct that? Whenever you come across complicated wordings like this, when they play with grammar like this in the questions, please go back to the question again, read the question again, check if you have marked the correct option. Please keep this in mind. Any confusing type of questions, spend 30 seconds more going back to the question, going through the answer, check if you have marked the correct one. Fluid compartments. Yes. What are the different fluid compartments? Body fluid compartments. Body actually has solid compartment and water compartment. The water compartment, we call it as total body water compartment. How much is your total body water? In any adult female, 55% of total body water. In adult male, 60% total body water. In babies, in infants, 75% total body water. This is how body fluid compartments are divided. Usually, for any example, we take adult male of 70 kg. So, any adult male of 70 kg who has 60% of total body water, how is this divided? 2/3 goes into the ICF. So, maximum goes into your cells. 1/3 into the ECF. So, if you want to make a calculation, 60% of 70 kg, you can do the calculation. 60% of 70 kg is 42 liter. So, any average adult male of 70 kg has 42 liters of total body water. How is this 42 liter divided? 28 liter into the ICF and 14 liters into the ECF. How is this 14 liter again divided? 10 liter into the interstitium and 4 liter into the plasma, because in the extracellular fluid outside the cells we have the space. The space is called interstitium. We have blood vessels. Blood vessels have plasma in them. So plasma is around 4 to 5 liters. This is how body fluid compartments are divided. And we have methods to measure this. How do you measure your body fluid compartments? Indicator dye dilution technique. It's a technique by which you induce dyes into the patient. If suppose I infuse a particular dye into the patient, if this dye has the property of occupying your total body water compartment, and you measure the volume of distribution of the dye, that will tell you how much is your total body water. If you take another dye which has the property of occupying your plasma compartment, and you measure the volume of distribution of that dye in your body, that will tell you how much is your plasma compartment. So we have different dyes for different compartments, and that we call it as indicator dye dilution technique. Let's see what are the different dyes that are used to measure different body compartments. Total body water compartment. How do you measure? I can use something which is like water. To measure total body water, I can give something which is like water. I can give heavy water. What is heavy water? Deuterium. tritium, or dyes like antipyrine, aminopyrine. All this can be used to calculate total body water compartment. So if I inject all this into the patient and I measure the volume of distribution, that will tell me how much is the total body water. ICF, there is no substance which will go only into the cells. So you can't measure ICF directly. ECF, how do you measure ECF? For measurement of ECF, which is the most abundant extracellular ion? Sodium. So I can give something which is like sodium, radioactive sodium, sodium thiocyanate, sodium thiosulfate, inulin, sucrose, mannitol. All this can be used to calculate ECF compartment. Interstitium. There is no direct method for interstitium. Plasma. To measure plasma, I can inject something which will occupy the plasma. Can I give plasma proteins? Yes, they occupy plasma compartment. Plasma proteins like albumin, radioactive iodine 125, or dye like Evans blue, all this can be used to calculate the plasma compartment. And this technique is called as indicator dye dilution technique. Over to the other topic in general physiology and cellular physiology, intercellular connections, cell junctions. Quickly, let's go through cell junctions. What are the different types of cell junctions? What is a cell junction? When you have two cells are connected by cell junctions. So it's a junction between two cells. And also remember, all your cells have to be connected to the body surface. So there are two types of junctions. One cell is connected to the other cell by a type of cell junction, and all the cells are connected to your body surface by another type of cell junction. Let's see what are they. The first type of cell junction, tight junction. Why is it called tight junction? Because it is very tight. It will not allow most of the substances to pass through. If it is very tight, it will form barriers. That's why it forms blood-brain barrier, blood-aqueous barriers, water-tight seals. So wherever you have to prevent the leak of water, like your intestine, where you have to prevent the leak of water from intestinal contents, or in your renal tubules, where you want to prevent the leak of water in urine. So all these places where you need a tight water seal, you have tight junctions. And tight junctions are made up of proteins called occludins and claudins. And if there is any mutation, defect in occludin or claudin, this can result in familial hypomagnesemia and hypercalciuria with nephrocalcinosis, because claudin is especially important for handling calcium and magnesium. Claudin is responsible for calcium and magnesium reabsorption. So if there is any mutational defect in claudin, magnesium and calcium handling by the kidneys would be affected. Yes, right, Dr. Mensaiko, right. So that is about tight junctions. Over to the other type of junction, gap junctions. So when you have a tight junction, you can also have a loose junction, but I can't call it a loose junction. I'll call it a gap junction. So if there is a gap between two cells, so this becomes a gap junction, otherwise called nexus. They are electrical coupling between the cells. So it forms syncytium. What is a syncytium? Where the whole organ contracts and relaxes together. It is called syncytium. What are the organs which will do this? Which organ will contract and relax together? Yes, your heart. That is why gap junctions are rich in cardiac muscle. Intestines, uterus, bladder, all this also will contract and relax together. What type of muscle is all this? Smooth muscles. Yes, cardiac muscles and smooth muscles are rich in gap junctions. Wherever you have a syncytium, the whole organ is moving together, you will have a gap junction. And also remember, tight junctions are almost absent in cardiac muscle. This is the structure of gap junction. Gap junctions are made up of connexons. So you can see 3 connexons in this image, 1, 2 and 3. Each connexon is made up of connexins. Let's count the connexins. 1, 2, 3, 4, 5, 6 connexins. So gap junctions are made up of connexons, and each connexon is made up of 6 connexins. Why am I talking about connexins here? Because connexins are related to mutations. There are mutational defect in connexins. This is the list of diseases related to connexin mutation. So anyway, the session is going to be available on YouTube. So later you can stop this and you can take a screenshot, or you can note down this. I'll just tell you which was the repeat question that was asked here. Connexin 32. Connexin 32 mutation results in which disease? Charcot-Marie tooth syndrome. That was a repeat question. Yes, very good, Dr. Nalakshmi Karthikeyan. Very good. Yes, Dr. Uma Pungundan. Happy to see you. So all these are connexin mutation defects. Let's move on to the other type of cell junction, zona adherens. I think this was what Dr. Med Psycho was talking about. Adherens, yes. It is made up of proteins called cadherins. What is the importance of zona adherens? Two cells will be connected by actin. If two cells are connected by actin, it is called zona adherens. And if you go into the structure of zona adherens, you will see that they are made up of cadherins. Mutations of cadherins are important because mutations of cadherins can result in hypotrichosis with juvenile macular dystrophy, a disorder related to cadherin mutation. Other type of cell junction, desmosome. Desmosome is made up of, when there are two cells which are connected by an intermediate filament. IF means intermediate filament. When two cells are connected by an intermediate filament, what are the intermediate filaments? Like desmin, laminin, keratin, vimentin, all these are intermediate filaments. When two cells are connected by intermediate filaments, this is called a desmosome. And desmosomes are made up of proteins called desmoglein and desmocolin. What is the clinical importance? Autoantibodies against desmoglein and desmocolin results in a skin disorder, pemphigus vulgaris. See, can you connect this with keratin? Keratin is a skin substance, and that is why it results in skin disorders, pemphigus vulgaris. So all the junctions that we had discussed till now, they are connecting one cell with that of the other cell. Now let's discuss about the cell junctions which connect all the cells to your body surface at the basolateral membrane. There are two types of cell junctions which do this: focal adhesions and hemidesmosome. Focal adhesions are made up of actin and hemidesmosomes are made up of integrin. Focal adhesions and hemidesmosome. That was a repeat question. These are the cell junctions which connect all the cells to your body surface. Yes, welcome Dr. Wondergate. Let me show you a previously asked question. In INI-CET May 2021 paper, patient presented with severe watery diarrhea resembling that of rice stool. Damage of which structure is likely to have resulted in this diarrhea? See, already I told you, watertight seals. Which junction forms watertight seals? Your tight junctions. So if you have to prevent the leak of water, as in diarrhea, there is something wrong with your tight junctions. Tight junctions have to be very tight. Only then you can prevent water leak. Tight junctions are made up of occludins, and that is why the other name for tight junction is zona occludin. Why is it called zona occludin? Because tight junctions are made up of smaller proteins called occludins. That's why the other name zona occludins. So the patient is having diarrhea, and damage of which of the structure would have resulted in this? Yes, tight junctions, zona occludens. So that was a discussion on general physiology. Over to nerve physiology. Only two topics from nerve physiology: membrane potential and nerve fiber classification. Membrane potential. What is your understanding of membrane potential? Membrane potentials are electrical signals. See, when someone touches me, how am I able to feel it as a touch? Because I have a touch neuron which is carrying this electrical signal into my brain. That's telling me that someone is touching me. If someone is going to slap me, now it is the same cheek and the same hands, but now it is not touch. I don't feel it as touch. I feel it as pain because I have a pain neuron which will carry this electrical signal and will tell my brain that now they are not touching you, they are hitting you. It is painful. So how are you able to carry so many different signals? Touch, pain, temperature, when you touch something cold, when you touch something hot. How are you able to carry all this? Because of electrical signals. What is the name of that electrical signal? Membrane potential. It's called as action potential. Just because of action potential, carrying all these impulses, we are able to feel so many types of sensations and we are able to do so many type of motor movements. So the basic electrical signal that is carried in your body is called as action potential. Before learning action potential, let's learn resting membrane potential first. RMP or rest. Yes, very good, doctor. Med Psycho, very good. Cholera, rice stool diarrheas. Let's learn resting membrane potential. What is resting membrane potential? Simple. When a cell is at rest. Rest means the cell is not conducting any electrical impulse. I'll take two electrodes. I'll place one inside and one outside. And I'm going to record the potential difference between inside and outside of this cell. This will give me inside of negative and outside of positive. Can you see that there is a potential difference between the inside and outside of this cell? Yes, this potential difference between inside and outside when the cell is at rest is called resting membrane potential. Which ion is responsible for maintaining resting membrane potential? Most important ion is potassium. See, of course, you have phosphates and proteins also present inside the cell, which can also help you to maintain the RMP. And sodium also up to a point it helps you to maintain RMP. But the most important ion is potassium. Why the most important ion is potassium? Let's say this is a classroom. So in this classroom, I have a door for girls and a door for boys. So if these are doors for boys and there are doors for girls. The class is at rest. I have not started the class. Class is at rest. I close all the boys' door. I am opening only the girls' door. Only the girls can move. Boys can't move. The strength of this class will depend on girls or boys. Girls only. Why? Because only girls' door is open. The same thing happens to a cell which is at rest. When a cell is at rest, all the doors are closed. Only potassium doors are open. Let's say girls are like potassium. So in a cell at rest, only potassium channel is open. Or I can say the cell is most permeable to potassium only at rest. That is why RMP depends on potassium ion concentration and not on any other ion concentration, mostly on potassium ion concentration. And of course, you have certain proteins and phosphates inside the cell, which can also help you partially to maintain your RMP. But the most important one is potassium. Now, what is action potential? Let's say the cell is in action. What is the action of the cell? The cell is actively conducting an electrical impulse. Now, what do? You take two electrodes, place one inside and one outside, and you record the potential difference between inside and outside. Now also, inside is negative when compared to outside. There is a potential difference between inside and outside. When the cell is in action, what is the action? The cell is actively conducting an electrical impulse. Now, if you measure the potential difference between inside and outside, this is called action potential. Simple. When the cell is at rest, the potential difference is called resting membrane potential. When the cell is in action, the potential difference is called action potential. So that is our basic understanding of action potential and resting membrane potential. And resting membrane potential, the value is not uniform. Different cells have different RMP values. The most important ones, RMP of neuron minus 70, RMP of skeletal muscle minus 90, myocardial cells, ventricular cardiac cells minus 90, SA node minus 55, RBC minus 10, GIT smooth muscles minus 65 to minus 45, retinal rods in your eyes minus 40, inner hair cells of the ear minus 60. All these are different RMP values. Next, let's move on to the action potential curve as such. What are the questions that can be asked from action potential curve? Ionic basis. What is the easy way to learn this? Listen. What is action potential curve? When you measure the membrane potential, the voltage on y-axis with time in milliseconds on x-axis over time, what is the potential difference that is happening? This is called action potential curve, and this is the action potential graph. Let's understand this graph. It starts with RMP, resting membrane potential. Yes, can anybody tell me this graph of action potential belongs to which cell? Yes, so many of you are listening to the class. Can anybody tell me this graph belongs to which cell? Can you look at the RMP and can you tell me this is more likely the action potential of which type of cell? Just now we saw the RMP values. Nobody knows. Look at the RMP. It is between minus 60 and minus 80. So almost the value is around minus 70. So which is that cell? Look into this. Neurons. Neurons have an RMP of minus 70. So this action potential curve belongs to neuron, nerve or the neuron. Let's read this. Resting membrane potential, RMP. What is the reason for RMP? RMP is due to potassium ions that we already saw. Because at rest, the cell is most permeable only to potassium. From the resting membrane potential, there is a beginning of action potential. Before action potential, there is a small yellow phase. This is called local potential. This one, this small phase is local potential. What is the reason for the local potential? You will come back to this classroom. Just the comparison of classroom. Yes, very good, Dr. Karthikeyan. Very good, Uma. Vishwanath, very good. So we'll come back to the classroom scenario. So in this class, I told you there are doors for boys and doors for girls. Boys are like sodium and girls are like potassium. When the cell was at rest, when the class was at rest, only girls' door was open. Now the class is going to start. It has just started. When the class has just started, see what I am doing. I am going to open one of the boys' door and one boy enters inside. So there is one boy who is entering inside. Only one boy, because I have opened only one of the boys' door and there is only one boy who had entered inside. And this boy who had entered inside, boys are like sodium. So let's say one sodium has entered inside. When one sodium has entered inside, sodium is a positive ion, but only one positive ion has entered inside. So only when one positive ion enters inside, you will have a small increase in positivity. You can't have a huge increase in positivity because only one positive ion came inside. There is a small increase in positivity. So the curve goes up like this, but only a small part because local potentials are due to one sodium ion entering inside or few sodium ions entering inside. So one boy entered the class, one sodium entered the cell. Because it is only one positive ion, small increase in positivity. That is called local potential. But this one boy who had entered the class, he is attending the class and he is finding that there are many beautiful girls in the class. So he has a boys group and he is messaging in his WhatsApp boys group. There are many beautiful girls in the class. So all of you come inside. So one boy who came inside, he is stimulating all boys to come inside. One sodium that entered inside is opening all the sodium channels and all sodium channels are entering. All sodium ions are entering inside. So all boys are coming inside. Boys are like sodium, Na plus, Na plus. All sodium ions are entering inside. So suddenly, if you have so many sodium ions coming inside, sodium is a positive ion, sudden influx of so many sodium ions, positivity suddenly increases. That is why from here, there's a rapid increase in positivity. RMP is called polarized state. Now it is going away from polarized state. So I call it as depolarization. It is getting depolarized. It is going away from polarity. So I call this phase as depolarization phase. What is the reason for this depolarization? Sudden entry of sodium ions, and that is called sodium influx. So there is a rapid increase in positivity. Now all boys have come inside. The class is full. I don't have space inside the class. I have to send some students out. I'm going to ask some of you to go out. See, if I say, please move out, girls will go out easily or boys will move out easily. Who will move out easily? Yes, definitely. The boys will not move because beautiful girls are inside the class. Girls are going to move. Girls are like potassium. Potassium is going to move out. Why in a cell it is more easier for potassium to move out? You have so many ions. You have sodium. You have many other ions. Why potassium is moving out easily? Because of the gradient. The normal gradient for potassium is normally potassium is more inside and less outside. Because of this gradient, it is easier for potassium to move out. That is why when I ask you to go out, potassium moves out easily. Think about sodium. Sodium is more outside and less inside. So it has to go against the gradient. That is difficult. But potassium can go along the gradient more easily. That is why potassium moves out. Again, potassium is a positive ion. If positive ion goes out, inside becomes negative. So inside becomes negative. That is why again it is coming back to negativity. So this phase where it is returning back to negativity, repolarization, it is returning to polarized state. So this is called repolarization. And what was the reason for repolarization? Potassium moving out. Potassium efflux. So depolarization, sodium influx, repolarization, potassium efflux. And potassium moving out, all this started at RMP. So it should stop at RMP. But it is not stopping at RMP. It goes even beyond RMP. So there's a small phase where it goes beyond. If it goes beyond RMP, then it is called hyperpolarization. So this becomes hyperpolarization phase. What is the reason for hyperpolarization? The repolarization was due to potassium moving out. Girls are moving out. Girls are very lazy. If I ask them to go out, immediately they won't go. They are chatting with each other. They are moving in. They are moving out. And that is why they are causing a fluctuation in the membrane potential. So potassium does this. Like lazy girls, potassium is a lazy potassium channel. This we call it as slow leaky potassium channels. So hyperpolarization is due to slow leaky potassium channels. Lazy girls or slow leaky potassium channels. So this is about the action potential curve. Quickly through this again. Depolarization, sodium influx. Repolarization, potassium efflux. Hyperpolarization, slow leaky potassium channels. RMP is because of potassium. Local potential is because of few sodium ions. And please remember, this depolarization and repolarization are because of voltage gated sodium channel and voltage gated potassium channel, because they are controlled by voltage. A change in voltage only is opening them. So they are voltage gated sodium channel and voltage gated potassium channel. But these leaky channels, they are always open. They are not controlled by the change in voltage. They are always open. They are always leaking. So they become leaky channels. So there's a difference between voltage gated channels and leaky channels. So that was about a learning of membrane potential. And we have two refractory periods in this action potential curve. First of all, what is a refractory period? Refractory means not responding. There are periods within the action potential curve when it will not respond. Yes, good, Dr. Karthikeyan and Med Psycho, lazy channels. Good. Absolute refractory period and relative refractory period. What is absolute refractory period? Absolutely, it will not respond. However, you increase your second stimulus, it will not respond. What is this absolute refractory period? From firing point. What is firing point? The end of local potential and the beginning of action potential. This is called firing point. The point from which local potential ends and an action potential is fired. This is called firing point. So from firing point up to 1/3 completion of repolarization, it is called absolute refractory period. And what is the reason for absolute refractory period? Closure of sodium inactive gates. There's a lot of molecular science behind this gating of sodium channels. It's not important for us. Just remember, absolute refractory period is because most of the sodium channels are going for the closed state. And it is the inactive gate. So closure of sodium inactive gates. From 1/3 repolarization until you complete the action potential. This is called relative refractory period. During this period, if you give a comparatively stronger stimulus, you can get another action potential because it is relatively refractory. It means relatively it will respond also. So absolute refractory period, absolutely no response. Relative refractory period, relatively you might get a response. So that was about the membrane potentials. Yes, over to repeat questions that were asked from this topic. INI-CET May 2022 paper. The question was, the curve was given. A and B in the graph below are representative of which of the following ions in terms of permeability for action potential? See, this is not action potential curve. It is permeability curve. In action potential, the permeability is increasing for the ion A. So, which is that ion which is entering first? Sodium, which causes depolarization. So, the first permeability, the curve is belonging to sodium. Later on, you have repolarization and the permeability for another ion is increasing. So, that is B, which is potassium. So, initially, sodium permeability increases. Later on, potassium permeability increases. Yes, because first it is sodium influx. Later on, it is potassium efflux. So, the first ion permeability increasing is sodium. The next one is potassium. So, A is sodium and B is potassium. And understand, this is not action potential curve. This is permeability curve. Yes, this question. Can you guess the answer for this question? Yes, doctor. What is the answer for this question? Yes, the portion marked D to E. Look at this curve. D to E is this portion. Repolarization. What is the reason for repolarization? Yes, potassium efflux. Efflux of potassium. So as a completion of membrane potential, we have just learned nerve membrane potential. Just let me tell you what are the differences between nerve membrane potential and heart membrane potential or cardiac membrane potential. Just the differences I'll tell you. So we have already finished nerve action potential. You know that. Heart has two type of fibers, cardiac ventricle and SA node. Yes, very good, Dr. Metsyko, very good. Cardiac ventricle action potential and SA node action potential. What is the special point about cardiac ventricle action potential? This is a cardiac ventricle action potential. Like nerve action potential, depolarization is due to sodium influx. Repolarization is due to potassium efflux. But the thing is, in between, there is a flat phase or a plateau phase. What is the reason for this plateau phase? Opening of L type of calcium channels. L means long-lasting type of calcium channels. And how is this responsible for the plateau phase? So if you look at this diagram, during phase 1 itself, potassium efflux has started, but it's a transient potassium efflux. During phase 3, completely there's a potassium efflux. But in between, there is a plateau phase because of opening of L type of calcium channels. What happens during phase 1? Potassium is beginning to move out. K plus is moving out. But in between, there is opening of L type of calcium channel, long-lasting calcium channel, and through this channel, calcium enters inside. Potassium is moving out and calcium is entering inside. Potassium is one positive ion moving out and calcium another positive ion moving in. One is moving out, one is moving in. Both are positive ions. That is why they balance each other and there is no change that is happening. It is just a plateau phase. There is no electrical activity during the plateau phase because one positive ion potassium entering inside, one positive ion calcium, one positive ion potassium moving outside and one positive ion calcium moving inside. Both balance each other. Now you understood the plateau phase? Yes, that is a special point about cardiac ventricle action potential. What about SA node action potential? Pacemaker potential. How does SA node become the pacemaker? Because of this slopey phase. Only in SA node action potential you can see this slopey phase, phase 4. So this slopey phase itself is a special point about SA node action potential. This is called the pacemaker potential or slow diastolic depolarization phase. That's a special point. What are the channels which will contribute to this? IF. IF means a funny channel. TCAL, transient type of calcium channel. NCX, sodium calcium exchanger. All this contribute to pacemaker potential. Another special point about SA node is L type of calcium channels are responsible for depolarization phase. In nerve, depolarization is due to sodium influx, but in SA node, depolarization is due to opening of L type of calcium channel and calcium influx. Yes, Dr. Medpsycho, correct. Yes, exactly like the delta wave in the ECG, correct. So at the beginning of action potential, there is a slopey phase. But delta wave, that is completely because of WPW syndrome, don't confuse that. But as a comparison, you can say it is just like the delta wave of ECG. So this is a slope here. Because you have this slope, already the slope is taking you towards positivity. Already it is going towards positivity. So from here, it is very easy to get an action potential. That is why SA node produces highest rate of action potential. Just think, if this is like the 0, ground floor, and this is like the first floor, and this is the second floor. If you have to climb to the second floor, from ground floor, it is very difficult. But already, if you have a lift which is carrying you to the first floor, from first floor to climb on to the second floor, it is very easier. So all other cells are climbing from 0, ground floor. But only SA node is climbing from first floor because it has this slopey phase. This slope is not present elsewhere in the body. Only in SA node you have this slope. It is a lift which is already carrying you to the first floor. That is why SA node is able to produce highest rate of impulse. More number of impulses are produced from the SA node, and that's why it becomes the pacemaker also. So these are the special points about SA node. What is the use of learning all this? Why are we learning all this? Yes, because to learn about antiarrhythmic drugs. If you can control any of the phase of action potential in the heart, you can regulate the heart rate. So these drugs are used as antiarrhythmic drugs. What are these antiarrhythmic drugs? Just the classification of antiarrhythmic drugs. Class 1 antiarrhythmics, voltage gated sodium channel blockers. So they block Depolarization phase. What are the drugs? 1A, 1B, 1C. 1A, procainamide quinidine, 1B, lidocaine mexiletine, and 1C, flecainamide and propafenone. Class 3 antiarrhythmics, potassium channel blockers. So they will block repolarization phase. What are the drugs? Amiodarone, ibutylide, dofetilide, and sotalol. Class 4 antiarrhythmics, calcium channel blockers, verapamil diltiazem. If they are calcium channel blockers, they will block this plateau phase of action potential in the heart. So these are class 1, class 3 and class 4 antiarrhythmics. I said class 1, class 3, class 4. What happened to class 2? Yes, class 2 acts on SA node. Beta blockers. They block the slope of pacemaker potential. Beta blockers. They decrease this slope of phase 4. Propranolol and metoprolol. And that is how they are also used as antiarrhythmic drugs. So that was a quick learning of membrane potential in nerve and heart. Let me show you a repeat question which was asked in INI-CET November 2022 paper. Ventricular action potential in the heart. Place them in sequence. Quickly, can you place it in sequence? Answer is A, B, C, D. The first event, opening of voltage gated sodium channel, and then this is the reason for depolarization, and then you have transient flow of potassium. Yes, that is responsible for the small phase, phase 1. This is phase 0. This is phase 1. Calcium channels are opening. This is the third one, responsible for phase 2. The plateau phase. This is the plateau phase. Repolarization potassium currents. Yes, this is responsible for the phase 3, which is repolarization phase. So the answer is A, B, C, D. In order, A, B, C, D. Yes, let me show you one more question which was asked in INI-CET recent 2023 paper. Upstroke of action potential. Phase 0 in SA node is due to calcium currents. Very good. Just now we saw depolarization in SA node is due to calcium currents, due to opening of L type of calcium channels and calcium currents. Over to nerve fiber classification. This is again a repeatedly asked topic, classification of nerve fibers. National Board is very favorite of asking questions from here. Let's quickly learn the classification of nerve fibers. There is a table given in Genome for classification of nerve fibers. Very complicated one. I'll teach you a simple method, quickly how to learn classification of nerve fibers. Just listen to this. It's called Erlanger-Gasser classification of nerve fibers. Two people, Erlanger and Gasser, they won Nobel Prize for this classification, and they classified nerve fibers as type A, type B, and type C. In A, you have A alpha, A beta, A gamma, and A delta. Then you have type B fibers and type C fibers. What are the functions of these fibers? So one easy method of learning this, how I remember this is with a small story. Now I'm going to tell you the functions of these types of fibers. A alpha, A beta, A gamma, A delta, type B and type C. What are the functions? Listen. First listen. You want to buy a car. What would you do? You go to a motor company and you meet the owner. Owner is called proprietor. You go to the motor company and you meet the proprietor. He takes you to the car. Once you are nearby a new car, what is the first thing that you will do? You will touch the car and you want to press. You touch and press. Then what will you ask him? Can I go inside the car? You want to go into the car. In. You want to go inside. Once you are inside a new car, what is the first thing we will do? You switch on the AC and you feel how cold it is. You are enjoying the chillness and you are asking him for the price of the car. You saw the company name, Audi company, you know the price of the car. So when you are enjoying this chillness and you are asking him for the price of the car, when he is telling you the price of the car, it is so costly that it is so painful to you. It is so painful. Now what you decide? I don't want a car and all. You call an auto. Let's go home by an auto. You call for an auto. Once you are inside the auto, you realize that there is no AC. It's not cold. It's very hot. And you are returning home with a painful heart. Inside the auto, there's no AC. It's very hot. Or you can see Katrina is there, very hot. And you are returning home with a painful heart. So this is the story. Now I'll tell you how to correlate with this Erlanger-Gasser classification. So the first type is A alpha. So what is the function of A alpha? A alpha type of nerve fiber, motor functions, and proprietor. I can replace this with proprioception. So what is the function of A alpha fiber? Motor fibers, and they help in proprioception. There are two types of proprioceptors. We have muscle, spindle, and Golgi tendon organ. These are the two proprioceptors. So A alpha helps in motor function and proprioception. The next one is A beta. What is the function of A beta? Touch and pressure. When someone touches you or when you sit on a chair, there is a pressure that is sensed by A beta. A gamma. In stands for intrafusal muscle fibers. What are these intrafusal muscle fibers? Intrafusal means the fibers that are present inside the muscle spindle. Let me show you the structure of a muscle. Any muscle, if this is any muscle, muscles have spindle shaped structures called muscle spindles. So if this is a muscle, this is a muscle spindle. The fibers that are present outside the muscle spindle, they are called extrafusal muscle fibers. And the fibers that are present inside the muscle spindle are called as intrafusal muscle fibers. So we have extrafusal fibers and intrafusal fibers. This intrafusal fiber is supplied by A gamma. So what is the role of A gamma? The nerve supply to the intrafusal muscle fiber is by A gamma. Then can you guess which is that nerve supplying extrafusal muscle fiber? A gamma supplies intrafusal fiber. Then which is the one that supplies extrafusal fiber? Which is the other motor fiber? A alpha, the other motor fiber. The first one, A alpha, is motor. So please understand, A alpha supplies extrafusal muscle fiber and A gamma supplies intrafusal muscle fibers. So that was about A gamma. We had alpha, beta, gamma. What is the next one? Delta. What is the function of A delta? Cold sensation. If you touch something cold or you enter into a cold room, cold sensations are felt by A delta. Painful sensations, especially fast pain or sharp pain, all this is carried by A delta. The next one, type B. What is the function of type B? Auto. Auto stands for autonomic fibers, especially preganglionic autonomic fibers. Type B, auto, autonomic fibers, preganglionic autonomic fibers. Then we have type C, again autonomic, but this one is postganglionic autonomic fibers. Postganglionic autonomic fibers, hot temperatures and pain, but this is dull or slow type of pain. So A delta carries fast pain, C carries slow pain. Type B carries preganglionic autonomic, and type C carries postganglionic autonomic. So that was about Erlanger-Gasser classification of nerve fibers. Very, very important. Questions are repeatedly asked from this table of Erlanger-Gasser classification. A word about susceptibility of these fibers. What is susceptibility of these fibers? Type A fiber, type B fiber, and type C fiber. Type A fiber is most susceptible to pressure and local anesthetic. Type B fiber most susceptible to hypoxia, and type C fiber least susceptible. How do we easily remember this? So one way how I used to remember is in MBBS, usually we are divided into A batch, B batch, and C batch students. And we are arranged alphabetically also. I think in all your colleges it is like that. You are arranged alphabetical order? Yes. So all the names starting with A, B, C, D and all, you will come under A batch. What are the difficulties faced by A batch students? My name is Abhirami. A followed by B also. So from LKG till now, wherever I go, I am roll number 1. The problem is when they make us to sit for an exam according to batch wise or alphabetical wise, I will be the first person sitting right in front of the examiner. I can't do anything. I only have to write my exam. But C batch students, names starting with STUVS, Vineet, Vishwanath, Varun, all these students, very happy students because they'll be sitting somewhere behind. Even camera cannot capture them. Very happy students. They don't get caught at all. They are least susceptible. A batch students are always under pressure. You make them sit in the front row. When you call for a Viva also, you call A batch students only first. So I'll be the first person to enter into a Viva session. But all B batch and C batch students, they'll wait outside. They'll get all the questions from me. Easily they'll go and answer. So every time you see, I will be under pressure. A batch students are always under pressure. So to relieve them, please give them some local anesthetic so that you can relieve them. C batch students, happy students, least susceptible. They don't get caught at all. Least susceptible. B batch students, in between A batch and C batch, they are suffering from lack of oxygen. They are getting hypoxic. So they are suffering from hypoxia. So A batch students are under pressure. Give them some local anesthetic. C batch students, least susceptible. They don't get caught at all. B batch students are in hypoxia. This is one easy way how I used to remember the susceptibility. However you want, you remember. But the thing is, you should know the concept behind this. That's all. So that was about nerve fiber classification. Yes, this was the question asked in the recent INI-CET 2023 exam. In the given cross-section of a muscle, the structure marked A is innervated by which of the following motor nerve fiber? Yes, can you guess the answer? Yes, A, gamma. What is the structure shown below? Spindle. They have marked a muscle spindle. So the muscle spindle, the fibers inside the muscle spindle, the intrafusal fibers. What is the nerve supply to the intrafusal fibers? A, gamma. Extrafusal fiber, A, alpha. Intrafusal fibers, A, gamma. The answer is A, gamma. So that was the completion of nerve physiology. Over to muscle physiology. A very important topic in muscle physiology. Star topic, excitation, contraction, coupling. Other topics are muscle fiber structure and tetanizing frequency. Quickly, let's do excitation, contraction, coupling mechanism. What is excitation, contraction, coupling? How an action potential excites a muscle and how the muscle contracts. This is called excitation, contraction, coupling. Let's learn the mechanism. When an action potential arrives in a muscle, this action potential moves through the covering membrane of the muscle called sarcolemma. The white or the gray matter is the sarcolemma, and you can notice that sarcolemma invaginates at certain points to form T-shaped structures like this. This is called a T-tubule. Sarcolemma invaginates to form T-tubules. So when action potential arrives, it passes through the sarcolemma into the T-tubule. If I zoom into the T-tubule, you can see the blue colored structures nearby. These are the SR, sarcoplasmic reticulum. So I can see one T-tubule along with two adjacent SR. This structure is called as a triad. One T-tubule along with two adjacent SR. So action potential goes into the T-tubule and nearby you have the SR. Let me zoom into the T-tubule. This is the T-tubule. When action potential goes into the T-tubule, on the T-tubule, I have DHP channels, dihydropyridine channels, which are voltage sensors. They will sense the voltage. When action potential arrives in the T-tubule, this will stimulate dihydropyridine receptors. When dihydropyridine receptors are stimulated, this would move inside and it will touch the ryanodine receptor. Where is ryanodine receptor present? On SR. On sarcoplasmic reticulum, you have ryanodine receptor. So DHP moves inside and it touches the ryanodine receptor. So there is a mechanical touching between the DHP and the ryanodine. When DHP touches the ryanodine, because of this mechanical connection, see, if this is DHP and this is ryanodine, DHP moves inside, touches ryanodine, ryanodine opens up. When ryanodine opens up, it releases calcium, and this calcium acts on myofilaments, actin and myosin, and that is how the muscle contracts. Now let me zoom into the structure of this actin and myosin. Let me show you how actin and myosin look like. The actin and myosin is the thick filament and actin is the thin filament. So this thick red one is myosin and actin is the blue one. The thin one is actin. The black line that you can see, these are Z lines. So you can see two Z lines. The space between two Z lines, this is called a sarcomere. So what you see here is the structure of a sarcomere. So in the structure of this sarcomere, you have thick filaments and thin filaments. When you look at this structure into the electron microscope, they will appear as different bands. So they appear as dark and light bands. What are the dark and light bands? So this band, which is very thick, made up of thick filament myosin, appears as a dark band and you call it as the A band. So this is the dark band, A band. In the center of the A band, there is one space where there is no overlap of actin. When there is no overlap of actin, this becomes a comparatively lighter zone, that is called H zone. So in the center of dark band, there is a comparatively lighter zone, H zone. And wherever you have actin, the thin filaments, it is very light. That is called the lightest zone, I band. So we have dark band, A band. In the center of dark band, comparatively lighter zone, H zone, and the lightest one is the I band. This is the structure of actin and myosin. When sarcoplasmic reticulum releases calcium, what is the fate of this calcium? This calcium is going to bind to this actin and myosin. It is going to cause contraction of the actin and myosin. Thereby the muscle is going to contract. So let's see what is the role of this calcium. First, let's learn how actin and myosin are all placed. These purple colored dots are all actin. On actin, you can see a thread-like structure, a rope-like structure, which is tropomyosin. On tropomyosin, you can find green colored dots, troponin C. This is the structure of actin. On actin, you have the rope, tropomyosin. On the rope, tropomyosin, you have troponin C. When calcium is released from SR, when SR releases calcium, this calcium binds to troponin C. When calcium binds to troponin C, the rope is lifted. What is the rope? Tropomyosin. Tropomyosin rope is lifted. When the rope is lifted, now you can see the myosin binding sites are exposed. This is the myosin binding site on actin. When calcium was not there, you are not seeing this myosin binding site. Only when calcium binds to troponin, the rope is lifted, thereby exposing myosin binding sites on actin. So these are the myosin binding sites. So the myosin head pops up and it binds to the myosin binding site. The red one is the myosin using high energy ATP. This is called cross bridging. So all the myosin heads, they form cross bridge with the actin. And after that, using high energy ATP, the myosin heads, they pull the actin closer. With the help of ATP, this is pulled closer. So myosin head are pulling the actin like this. This is called a power stroke or sliding filament theory. Because of power stroke, all the actins are moving closer. When all the actins are moving closer, the whole muscle contracts. This is how the whole muscle contracts. That is the mechanism of contraction. Now the muscle should relax. How does the muscle relax? Again, there is binding of ATP. When ATP binds, all the myosin heads go back and the actin goes back and there is relaxation. So how does the muscle relax? Because of binding of ATP. After contraction is over, for relaxation also again you need ATP. Again, when ATP binds to myosin, this ATP pulls the myosin head, actin is pulled back, muscle relaxes. So please understand, not only for contraction, for relaxation also you need ATP. So that is the role of ATP here, and that is the clinical importance. After death of any patient, in the struggle to death, any patient, muscles would be in the contracted state. But after death, there is no ATP. So the muscles can't relax. So they remain in a sustained contracted state. That is called rigor mortis. The sustained contracted state of the muscles after death of the patient because of lack of ATP is called rigor mortis. So that is the mechanism of excitation contraction coupling. One question based on this on INI-CET May 22 paper. Myosin ceases to be in contact with actin filament as a result of, yes, attachment of ATP. Just now I told you, when ATP attaches, myosin is going to get detached from actin. So myosin ceases to be contact with actin filament because of binding of ATP. Again, when ATP binds, myosin comes back. It is moving away from actin. So this is, the question is actually, how is the muscle relaxing? Attachment of ATP helps in relaxation. Another question based on this, which was asked in INI-CET 2020 paper. In skeletal muscle, dihydropyridine and ryanodine receptors are coupled by mechanically. Yes, just now I told you, when action potential arrives, dihydropyridine moves inside, it touches the ryanodine. So it is a mechanical coupling. They are touching each other. So it is a mechanical coupling. Yes, another question which was asked in recent INI-CET 23 paper. Arrange the following bands in the sarcomere from periphery to the center. So from periphery to center, answer is Z line, A band, H zone. In the center of H zone, there is an M line. See, Z line, then you have A band. In the center of A band, H zone. In the center of H zone, you can see a line. This is called M line. So the centermost part is the M line. In the center of H zone, this is called as the M line. So accordingly, the answer also 1, 3, 4 and 2. Over to tetanizing frequency. Usually the question asked in tetanizing frequency is, how do you calculate the tetanizing frequency? What is tetanizing frequency? When you apply a particular strength of stimulus and the muscle goes for tetanus. So at which particular strength of stimulus the muscle goes for tetanus? That is called tetanizing frequency. The formula is 1 by contraction period. Just the formula, 1 by contraction period. So in case if they give you the contraction period, you should know how to calculate the tetanizing frequency. So in this question, can we calculate tetanizing frequency? A skeletal muscle of latent period, contraction period, relaxation period, 10 milliseconds, 40 millisecond and 50 millisecond respectively. So the formula is 1 by contraction period. So here contraction period is 40 milliseconds. So 1 by 40 millisecond. So this will give me 25. So the answer is 25 here. If you do 1 by 40 millisecond, you will get 25. So that is the formula to calculate tetanizing frequency. It's over to cardiovascular physiology. The high yield topics in cardiovascular physiology: baroreceptors, BP regulation, very important topic. JVP, exercise physiology, heart sounds, Poiseuille's law, cardiac cycle, cardiac output and cardiac action potential. So let's do that quickly. Blood pressure regulation and baroreceptors, very important topic. BP regulation. There are three types of blood pressure regulation: short-term regulation, intermediate regulation and long-term regulation. What is short-term regulation of blood pressure? There are three mechanisms for short-term regulation: baroreceptor reflex, chemoreceptor reflex and CNS ischemic response. They have their own threshold. Any variation of BP between 60 to 180 millimeter of mercury, baroreceptors will take care. When blood pressure falls less than 60 millimeter of mercury, chemoreceptors will take care. When BP falls less than 40 millimeter of mercury, CNS ischemic response will take care. Intermediate regulation, capillary fluid shift. This is the intermediate regulation. Long-term regulation is RAS. RAS is renin-angiotensin-aldosterone system. But also remember, RAS can be intermediate also. So RAS is like intermediate to long-term. Blood pressure regulation. Let's discuss in detail. Baroreceptor reflex. What is the mechanism of baroreceptor reflex? The baroreceptors. Where are the baroreceptors located? On the arch of aorta, they are called aortic arch receptors. And on the internal carotid artery, they are called carotid sinus receptors. They are basically stretch receptors. Baro means pressure. They respond to pressure. Whenever there is an increase in blood pressure, this will be sensed by the aortic arch receptors and carotid sinus baroreceptors. The stretching is sensed by these receptors. Whenever the blood pressure increases, it is sensed by aortic arch and carotid sinus receptors, and they will stimulate two nerves: vagus nerve from aortic arch receptor, the 10th cranial nerve, and glossopharyngeal nerve, 9th cranial nerve from carotid sinus receptor. And these nerves, they carry this impulse into my brainstem. They reach the medulla because medulla has the center for regulating blood pressure. The center is called NTS, nucleus tractus solitarius. They stimulate nucleus tractus solitarius. What is the role of nucleus tractus solitarius? Nucleus tractus solitarius, this can activate the parasympathetic nucleus and it inhibits the sympathetic nucleus. When sympathetic nucleus is inhibited, what will happen to BP? There is a fall in BP. A rise in BP through baroreceptor reflex causes a fall in BP. This is called baroreceptor reflex. When BP falls, if you inhibit the sympathetic nucleus, along with BP, heart rate also will decrease. When sympathetic is inhibited, heart rate decreases. This inverse relation between increase in blood pressure causing decrease in heart rate, this alone is called as Mary's law. What is Mary's law? Increase in blood pressure through baroreceptor reflex, how it causes a decrease in heart rate. This inverse relation is called as Mary's law. That was about baroreceptor reflex. One question which was asked in the recent paper, INI-CET 2023 exam. Which of the following is incorrect with respect to baroreceptors present in the carotid sinus? They are located in the deep smooth muscle layer. No, they are located in the adventitious layer, not in the deep muscle layer, in the adventitious layer. They need the support of electromechanical transducers. Yes, of course, they are baroreceptors. They are sensing pressure. Pressure is a mechanical stimulus, and that is causing action potentials in these nerves. So it is an electromechanical transducer, correct. Carotid sinus, ninth cranial nerve. Yes, it's the glossopharyngeal nerve. They express several non-selective cation channels. Yes, the flow of cation channels, the flow of cations through these channels is responsible for action potential. So the correct answer, incorrect statement is option A. INI-CET 2020 question. Which of the following events occurs immediately when a person changes his position from supine to standing? So when you change your position from supine to standing. So when you stand up, suddenly there is a fall in BPS. All blood goes to your lower limb. So blood pressure decreases. Suddenly when there is a drop in the blood pressure. When blood pressure increases, baroreceptors are firing. When blood pressure decreases, there is decreased firing from the baroreceptors. So the answer is option A, decreased firing from the baroreceptors. INI-CET 23 paper, there was a question on Wynn-Kessel effect. Wynn-Kessel effect is shown by all except. What is this Wynn-Kessel effect? Wynn-Kessel is, see, this is a Wynn-Kessel from a canal. If you want to pump fluid water out of it and you want to pour water like this, it should pass through a Wynn-Kessel. What is that Wynn-Kessel? It is a large reservoir which can hold the fluid water and it can pump the water out. So in your body, from the heart, when blood is pumped out into the organs, it goes through the large arteries, especially aorta, renal arteries, carotid arteries. All these are large arteries. When blood goes through the large arteries, especially aorta is a highly elastic structure, and also other large arteries. Because of the elastic recoiling property, they will expand to hold the blood and they will recoil back with a great force to pump the blood. What is the use of this recoiling back? Only if aorta is recoiling back, it will pump blood to all parts of the body. So only because of this Wynn-Kessel effect of the aorta and large arteries, they are recoiling back and pumping blood to every part of the body. So that is called the Wynn-Kessel effect. It is not present in small arteries like radial artery. It is present only in large arteries. So it is shown by all except radial artery. Over to cardiac cycle, another important topic from cardiac physiology, cardiac cycle. Cardiac cycle, the graph itself is a very complicated graph. So let's try to learn this graph in a very simple way. We'll split this graph and we'll try to learn this in a simple way. First, let me tell you what is your basic understanding of cardiac cycle. Every time your heart beats, what is the change in the pressure and what is the change in the volume inside the heart? This is called cardiac cycle. The pressure change and volume change inside the heart for every heartbeat. Every time your heart is beating, what is the pressure change and what is the volume change? That is called cardiac cycle. So let's learn this cardiac cycle graph by using the pressure changes and the volume changes. So that is why in the graph for cardiac cycle, you have pressure in millimeter of mercury and volume in ml, because it is the pressure and volume change inside the heart. Let's first learn the pressure curves. There are three pressure curves in cardiac cycle diagram. The first pressure curve, let me trace that in yellow color. This one, the topmost pressure curve. How do we label this pressure curve? Look at the pressure variations of this curve. It varies between 80 to 120 millimeter of mercury. What is 120, 80? your normal blood pressure. How do you measure the blood pressure? By using sphygmomanometer on the brachial artery. But is this the pressure which started in the brachial artery? No, this is not the pressure which started in the brachial artery. It is the pressure which started in the first blood vessel from the heart. Which is your first blood vessel from the heart? Aorta. So what is 120/80? Aortic pressure only is 120/80. So whichever curve which has 120/80 millimeter of mercury variations in pressure belongs to the aorta. So let me label this curve as aortic pressure curve. So the topmost curve 120/80 is aortic pressure curve. There is a huge curve, the red colored curve, a very big curve, the pressure variations of 0 to 120. Such huge variations in pressure, which part of the heart can produce? Only the big chamber of the heart. Which is the biggest chamber in the heart? Atrium or ventricles? Ventricles. So if you see a huge chamber, huge pressure difference, only a big chamber of the heart has produced this. Which is that big chamber of the heart? Ventricle. So the biggest part, the biggest curve belongs to the biggest chamber, ventricles. So this is the ventricular pressure curve. You can also see a small green curve. I'll trace that in green color. Very small curve. Not much variations in pressure you can see. Very small curve. It is not even reaching 20. Small variations in pressure, only a small chamber can produce. So this belongs to the small chamber atrium. Atrial pressure curve. So we can see aortic pressure curve, ventricular pressure curves and atrial pressure curves. These are the pressure curves. Volume curve. There is a one volume curve. Which volume are we more worried about? Atrial volume or ventricular volumes? Ventricular volume. Ventricle only is the big chamber. Ventricular volume only is more important. So there is one volume curve which belongs to the ventricle. Let me label this as ventricular volume curve. So we have 3 pressure curves and 1 volume curve. So that is about the different curves that you identify in the cardiac cycle diagram. Over to phases of the cardiac cycle. How would you label the phases in the cardiac cycle? So when you learn about the phases in the cardiac cycle, first understand what is cardiac cycle. Every time your heart beats, what is the pressure change and the volume change? That is called cardiac cycle. So every time your heart beats like this, how is the heart beating? It is contracting and relaxing. So contraction and relaxation. So what are the phases of cardiac cycle? Contraction and relaxation. These are the phases of the cardiac cycle. Contraction is called systole and relaxation is called diastole. We have 2 different chambers, atrium and the ventricle. So atrial, systole, diastole, ventricular, systole, diastole. These are the phases of cardiac cycle. Atrial systole, atrial diastole, ventricular systole, ventricular diastole. So let me label that. So the first phase is atrial systole. The initial phase is atrial systole followed by atrial diastole. Atrial diastole is a very insignificant event. It's almost negligible event. So we are not including that. Then we have ventricular systole, ventricular diastole. So followed by ventricular systole and ventricular diastole. These are the phases of the cardiac cycle. Now in between, let's put valvular events into this. At the end of atrial systole, if this is the atrium has pumped blood into the ventricles. At the end of atrial systole, this valve closes. What is this valve? AV valve closes. So after atrium has pumped blood into the ventricles, AV valve closes. So at the end of atrial systole, you can mark AV valve closure. So at the end of atrial systole, AV valve closes. When AV valve closes, blood is in the ventricle. Now which valve will open? The ventricle is filled with blood. Ventricle will open into the aorta. So now the aortic valve opens. Aortic valve opens. and blood flows into the aorta. So aortic valve opens. Can you see? AV valve closure followed by aortic valve opening. AV valve closes followed by aortic valve opening. When aortic valve opens, blood flows into the aorta. Ventricle is contracting and pushing the blood into the aorta. So this has ventricular systole. When aortic valve opens, ventricle is contracting. So this is ventricular systole. At the end of ventricular systole, blood has gone into the aorta. So aortic valve closes. Now again, which valve will open? AV valve opens. When AV valve opens, blood flows from atrium into ventricle and ventricle is filling. So ventricular diastole. There's ventricular diastole. This is how we fit valvular events into this. When AV valve closes, an aortic valve is going to open. AV valve has closed. Aortic valve is just going to open. In between, there is a small phase. So this phase, I'll mark that in green color. So this phase after AV valve closure and before aortic valve opening. See, AV valve has closed. Aortic valve is just going to open. So there's a small phase where both the valves are closed. When both the valves are closed, the volume in the ventricle cannot change. So this becomes isovolumetric phase. Isovolumetric phase. The volume in the ventricle is not changing because both the valves are closed. So it becomes isovolumetric phase. And it is followed by ventricular systole. Ventricle is going to contract. So this is called isovolumetric contraction phase. Isovolumetric contraction phase. At the end of isovolumetric contraction phase, aortic valve opens and there is ventricular systole. Ventricle pushes the blood into the aorta. Now aortic valve closes. There is opening of AV valve. But here also there is a small gap. Aortic valve has closed. AV valve is just going to open. You have a small period where both the valves are closed. So this period where both the valves are closed, again volume cannot change. It becomes isovolumetric. But this is going to be followed by diastole. So it is called isovolumetric relaxation phase. So we have isovolumetric contraction phase, isovolumetric relaxation phase. At the end of isovolumetric relaxation phase, AV valve opens and ventricle is going to get filled up. This is called ventricular diastole. Ventricle is going to get filled up. What are the phases of ventricular filling? When you say ventricle is going to get filled up, it fills up in three phases. Initial rapid filling phase, then we have a slow filling phase. The reason for rapid filling phase is atrial pressure is more, ventricular pressure is less. Atrial pressure is more and ventricular pressure is less. Because of this pressure gradient between the atrium and the ventricles, rapidly blood is pouring from atrium into the ventricles. And that is called rapid filling phase because it is rapidly pouring, rapid filling phase. And after some time, when that gradient is slowly destroyed, it becomes slow filling phase. So rapid filling phase and slow filling phase are because of the pressure gradient between atrium and the ventricles. Because of the pressure difference, automatically blood is pouring rapidly and then slowly. At the end of slow filling phase, still some more blood is present in the atrium. Now, how will you push this blood into the ventricles? Rapid filling and slow filling, automatically it poured because of the gradient. After the gradient is destroyed, even now there is some blood. Now the atrium will contract to push blood into the ventricles. So atrium contracts and there is ventricular filling. So the third part of filling is atrium is contracting and therefore there is ventricular filling. These are the phases of ventricular filling or ventricular diastole. So in this cardiac cycle diagram, we can fit heart sounds into this. When will you hear a heart sound? Whenever a valve closes, we hear the heart sound. AV valve closure causes first heart sound. This is the lub sound. Aortic valve closure causes second heart sound. This is the dub sound. Lub dub sound. Lub is important because L for loud sound, long duration sound, low frequency sound. So lub is loud, L for loud, L for low frequency, L for long duration sound. And dub is exactly the opposite. S3. Sometimes we can hear a third heart sound. This is heard during this rapid filling phase. Rapidly, when blood is pouring from atrium into the ventricles, the turbulence creates a noise. This is called S3. The rapid filling phase, third heart sound S3. When will you hear third heart sound S3? This is usually heard in high demand states. High demand states like children or athletes, or high demand state like pregnancy. So in all this we can hear S3 sounds. Pathologically, in heart failure. So S3 can be both physiological and also pathological. S4. Is there any fourth heart sound? Yes. During this phase, when atrium is contracting and ventricle is filling, you can hear S4. But S4 is purely pathological. Normally, you will never hear S4. It is purely pathological. Only in left ventricular hypertrophy, you will hear S4. Otherwise, S4 is never heard. Why do you hear it in left ventricular hypertrophy? See, when atrium is contracting and ventricle is filling, normally there is no noise. But if your ventricle has been hypertrophied like this is left ventricular hypertrophy. Now, if your atrium is contracting against the hypertrophied ventricle, now it produces a noise. Just imagine if normally if you close the door, there is no noise. But just think during rainy season when the door wood is just expanding little bit and now you close the door, you will hear some noise. So normally when you close the door, there is no noise. But when the wood has expanded, it has enlarged. Now when you close the door, you hear the noise. Same way, if your ventricles are normal, there is no S4. But if your atrium is contracting against hypertrophied ventricle, then it produces the noise S4. So S4 is purely pathological. Only in left ventricular hypertrophy you can hear S4. And that is how we fit heart sounds into this cardiac cycle diagram. So that was a quick learning of the cardiac cycle diagram and the events in the cardiac cycle. Over to cardiac output, another important topic in cardiac physiology. Measurement of cardiac output. How do you measure cardiac output? Cardiac output can be measured by using Fick's principle. Measurement of cardiac output by using Fick's principle. So according to Fick's principle, what is Fick's principle? If this is any organ, the oxygen consumed by this organ, how will you measure? Arteries are bringing blood into this organ and veins are removing this blood. If I want to know how much oxygen has been consumed by this organ, what do? You subtract both. Arterial oxygen minus venous oxygen will give you how much oxygen has been consumed by the organ. So oxygen consumption by any organ is equal to arterial oxygen minus venous oxygen, AV oxygen difference multiplied by or the blood flow times the blood flow multiplied by the total blood flow. So oxygen consumption by any organ is equal to arterial oxygen minus venous oxygen times your blood flow. Let me keep blood flow on one side. I'll keep blood flow on one side. Blood flow is equal to oxygen consumption divided by AV oxygen difference. What is the blood flow of the heart? Blood flowing out of the heart is nothing but your cardiac output. So in heart, I can say blood flow or cardiac output is equal to oxygen consumption divided by AV oxygen difference. And this is called the Fick's principle for calculation of cardiac output. By using Fick's principle, Cardiac output is equal to oxygen consumption divided by AV oxygen difference. I think that was a question asked in INI-CET November paper 2022. Cardiac output can be calculated from. You can use fixed principle for calculating cardiac output, or the other alternative methods are thermodilution, by which we use cold saline method. You inject cold saline and you measure the temperature of the blood coming out of the pulmonary artery. That is called thermodilution method. Echo scanning can be done. So A, C and D can be used to calculate cardiac output. Ventilation perfusion ratio. What is this? VQ ratio. VQ ratio is related to respiratory physiology, lung function test. It is not a method for measuring cardiac output. Poiseuille-Huygens equation. This relates the blood flow directly proportional to size of the blood vessel. Yes, a smaller blood vessel flow is less. In a larger blood vessel, the flow is more. So this relates the size of the blood vessel to the flow. I'll write the complete equation of Poiseuille's law. Flow is directly proportional to pi into delta P into size of the blood vessel, which is given by radius r to the power of 4 divided by 8 times viscosity into length. This is called the Poiseuille-Huygens law. Pi into delta P into radius to the power of 4 divided by 8 times viscosity into length. There was a question based on Poiseuille's law, which was asked in INI-CET May 22 paper. Below are two blood vessels shown. Assuming the pressure along both the blood vessels is same and both of them follow linear flow pattern, what will be the amount of blood flow in the blood vessel A when compared to the blood vessel B? So this is blood vessel A and blood vessel B. So let's write the Poiseuille's law. Flow is directly proportional to pi into delta P into r to the power of 4 divided by 8 times viscosity into length. So this is for the smaller blood vessel, which has diameter D and length L. It means radius is r. Now see what is the change that has happened in the bigger blood vessel. Diameter has doubled. So when you say diameter has doubled, it means radius also has doubled. So r has become 2r. Length has doubled. L has become 2L. So I'll put that change. L has become 2L. So now the change becomes 2r to the power of 4 divided by 2L. All others are same. Don't cancel this 2 and 2. 2 to the power of 4 is 16. So flow is directly proportional to 2 to the power of 4 is 16 divided by this 2. I can cancel all others because it is same for both the blood vessels. What is the change between both the blood vessels? Radius and the length. All others are same. So 2 to the power of 4 is 16 divided by 2. 16 by 2 will give me 8. So there is a change in 8 times the flow in smaller blood vessel when compared to the larger blood vessel when compared to the smaller blood vessel. Yes, there was a question recently asked on JVP. Quickly, let's do JVP. What is JVP? Jugular venous pressure is called as JVP. What is your understanding of JVP? JVP means the jugular veins are directly draining into the right atrium, especially the internal jugular vein, which directly drains into the right atrium. So whenever you want to measure the pressures in the right atrium, an indirect way of doing this is measuring the jugular venous pressure, because it will tell me how much is the right atrial pressure. This is called the two-scale method. You put the patient in 45-degree inclination and using two scales, in bright light, turn the head to the left side and note for the JVP pulsations on the neck. When you use two scales for measuring this, one scale is placed on the sternal angle like this, and the other scale is placed at the point where you see the highest pulsations. You measure this distance. So this distance is around 4 centimeter from the sternal angle. So what is the normal JVP? It should not be more than 4 centimeter from the sternal angle. But when I give JVP, it is a measure of right atrial pressure. So I should say how much is the value from the right atrium directly. From the sternal angle, it is 4 centimeter. How much it is from the right atrium? From the sternal angle, right atrium is at a distance of 5 centimeter inside my chest wall. So if I have to give the exact JVP, it should be 4 plus 5, 9 centimeters from the right atrium. So two ways of giving JVP. Either 4 centimeter from the sternal angle is correct, or add another 5 centimeter and you'll give it as 9 centimeter from the right atrium. Both are correct. When you record this JVP on a monitor, it can give you different waves. These are the different waves of JVP: A, C, X, V and Y. What does these stand for? JVP means jugular venous pressure or jugular venous pulse, which is a measurement of right atrial pressure. So one easy way of doing this is you correlate waves of JVP only with the atrial events. Why? Because JVP is the measure of atrial pressure, right atrial pressure. So correlate JVP with atrial events. A wave in JVP, A for atrial contraction. C wave in JVP, C for tricuspid, movement of tricuspid. See, when will the tricuspid move? Or it's called the tricuspid bulge. When the tricuspid valve is bulging, you can see the C wave. Tricuspid valve will bulge during isovolumetric contraction phase. When both the valves are closed and the pressure is rising, automatically the tricuspid valve is going to bulge. So during isovolumetric contraction phase only, the valve is going to bulge. So I can say C wave is seen during isovolumetric contraction phase. X for atrial relaxation, X for relax, X. V for atrial venous filling and Y for atrial emptying. So all these are the different waves that you get on the monitor when you record a JVP, and just correlate this with only the atrial events. These are the normal JVP waves. But sometimes you can see pathological variations of JVP, large A waves and absent A waves. When will you get large A waves in a JVP? You just think, what is A wave due to? A wave is due to atrial contraction. When will this wave become larger? If the atrium is contracting against any kind of obstruction in the right side of the heart. In the right side of the heart, if there is any obstruction, if the atrium is contracting against the obstruction, it will become larger. So what are the right side obstructions that you can have? Tricuspid stenosis, yes, tricuspid valve is on the right side. Pulmonary stenosis, yes, pulmonary valve is on the right side. Right atrial myxoma, myxoma means a tumor, a growth on the right side of the heart. Pulmonary hypertension, because pulmonary artery is on the right side. So all these are causes for large A waves. So large A waves are seen in any kind of right-sided obstructions in the heart. And this we call it as Cannon waves or giant A waves. Absent A waves. When will you not see an A wave? What is A wave due to? Atrial contraction. If atrium is contracting properly, you will see A wave. If atrium is not contracting properly, you will not see an A wave. When will the atrium not contract? Fibrillation. If your heart is beating normally like this, you can see A wave. Contractions. But if your heart is vibrating like this, it is fibrillating like this, there is no proper contraction, so there is no proper A wave. So in atrial fibrillation, there is no A wave, which is called as absent A waves in AF, atrial fibrillation. Yes, let's see if you are able to answer this question, which was asked in INI-CET November 21 paper. Which of the following waves corresponds to an isovolumetric contraction of JVP? What happens in isovolumetric contraction? C for tricuspid bulge. When will the tricuspid bulge? During isovolumetric contraction, when both valves are closed, because the pressure is rising, the valve is bulging. So this is C. Over to exercise physiology. One repeat question in AIMS 2018, which was asked from exercise physiology. In a 100-meter dash, most of the energy consumed by skeletal muscles to replenish ATP is derived from. Okay, so let's do the answer for this. What are the energy sources when you run? Up to first 10 seconds, phosphocreatine will give you energy. 10 seconds to 1 minute from glycolysis. After 1 minute up to 2 to 4 hours, it is oxidative metabolism. So the question is actually a 100-meter dash. 100-meter dash you will run in around 10 seconds. So the immediate source of energy here is phosphocreatine. The answer to this question is phosphocreatine. Over to renal physiology. The important topics in renal physiology: renal absorption and secretion, ADH and SiADH, glomerular filtration, countercurrent mechanism, and JG apparatus. Quickly, let's go through GFR first. Glomerular filtration. What is glomerular filtration? GFR means the volume of fluid filtered in all the glomeruli in both your kidneys per minute. This is called normal GFR, glomerular filtration rate. The normal value is 125 ml per minute or 180 liters per day. Normal urine output is 1 liter per day. GFR mainly depends on Starling's forces. The Starling's forces are hydrostatic pressures and oncotic pressures. Understanding of these pressures is very important to understand the pressures acting at the glomerulus. To derive the formula for GFR, you need an understanding of this. Let's do this. Hydrostatic pressures and oncotic pressures. Hydrostatic pressure is denoted by capital P and oncotic pressure is denoted by pi. What is a hydrostatic pressure? Hydrostatic pressures are pushing forces. Have you done like this? Have you played like this when you water the plants in the garden? When you close half the nostril of your pipe like this, water is pushed out with a great force. This is called hydrostatic pressures. They are pushing forces. So all hydrostatic pressures are pushing forces. Hydro means water. The water component contributes to pushing force. It means wherever you have hydrostatic pressure, it will push the filtration to the other side. Oncotic pressures. Oncotic pressures are contributed by plasma proteins. Plasma proteins contribute to oncotic pressure. And plasma proteins are like this sponge. What will happen if you put sponge in water? The sponge will keep on pulling the water. It will keep on absorbing the water. So wherever you have oncotic pressure, it is a pulling force. Hydrostatic pressures are pushing forces and oncotic pressures are pulling forces. If you remember this concept, understanding of GFR becomes very easy. So wherever you have hydrostatic pressure, pushing force. Wherever you have oncotic pressure, pulling force. Now let's apply these pressures on the glomerular and on the tubular side. On the glomerular side and on the tubular side. So on the glomerular side, PGC, hydrostatic pressure in the glomerular capillary. Pi GC, oncotic pressure in the glomerular capillary. PT, hydrostatic pressure in the tubule, and pi T, oncotic pressure in the tubule. Now of these forces, there are two forces which will favor your filtration, GFR, and two forces which will oppose filtration. Let's see what are they. What are the two forces which favor filtration? PGC and pi T, because PGC is hydrostatic force in the glomerular capillary. Hydrostatic forces are pushing forces. They will push the filtration into the tubule, thereby helping in GFR. Pi T, oncotic pressure in the tubule, pulling force. This would pull the filtration to its side in the tubule. So this again is favoring your GFR. What is the normal direction of GFR? From the glomerulus into the tubule. This is the normal direction of GFR, and both these forces are favoring filtration. So PGC plus pi T favoring force. What are the opposing forces? Exactly in contrast. Pi GC and PT, because PT is pushing force, hydrostatic force, but it is pushing from the tubule into the glomerulus. See, from the tubule, it is pushing into the glomerulus. So again, it is going in the reverse direction. So PT opposes filtration. Pi GC, oncotic pressure in the glomerulus. It is a pulling force. This will pull the filtration from the tubule into the glomerulus, again in the reverse direction. So PT and pi GC, they are two opposing forces. So two forces which favor filtration and two forces which oppose filtration. Now, what is the formula for GFR? GFR is directly proportional to net filtration pressure. What is net filtration pressure? Net filtration pressure is you take the favoring forces and from the favoring force you subtract the opposing force. You will get net filtration pressure. What is the favoring force? PGC plus pi T minus PT plus pi GC. This is the formula to calculate net filtration pressure. So using this formula, you can, if they give you values, you can just substitute into these pressures and you can calculate the net filtration pressure. This is how we calculate GFR. JG apparatus, juxtaglomerular apparatus. What is juxta? Juxta means nearby. Glomerulus means nearby the glomerulus. There are three cells which are present nearby the glomerulus and they act as juxtaglomerular apparatus. The first one, JG cells. What is the function of JG cells? JG cells produce renin. Macula densa. What is the role of macula densa? It helps in TG feedback mechanism to regulate tubuloglomerular feedback mechanism. And then we have extraglomerular mesangial cells. Extraglomerular mesangial cells. They are just supportive cells. Sometimes they produce erythropoietin, sometimes renin also, but mainly supportive cells. So these three cells together form the JG apparatus, juxtaglomerular apparatus. Macula densa. What is the location of this macula densa? Macula densa is located exactly at the junction between the thick ascending limb and the distal convoluted tubule. In the structure of nephron, if you see, if this is the glomerulus, the PCT, loop of Henle, the thick ascending limb continues as the DCT. Glomerulus, PCT, loop of Henle, thick ascending limb continues as distal convoluted tubule. Exactly at this junction between the thick ascending limb and the DCT, you have macula densa. At the junction between thick ascending limb and the DCT, we have macula densa. And that macula densa helps in TG feedback mechanism. Yes, macula densa is made of specialized cells located at the junction between thick ascending limb and the DCT. Question asked in INI-CET November 22 paper. ADH, antidiuretic hormone. What is the role of ADH? The antidiuretic hormone, it helps, the word itself, the name itself, antidiuresis. What is diuresis? When more water flows out in urine, that is called diuresis. Then what is antidiuresis? If water is absorbed into the blood, it is called antidiuresis. So the main function of ADH is water reabsorption. This is the main function of ADH. There are two diseases related to ADH. ADH contributes to around 15% water reabsorption from the kidneys. Excessive ADH and lack of ADH. When you have excessive levels of ADH, the disease is called SIADH, syndrome of inappropriate ADH secretion, inappropriately so much of ADH is secreted. That is called SiADH. When there is lack of ADH, this is called diabetes insipidus. Diabetes insipidus. Two diseases related to ADH. SiADH and diabetes insipidus. Renal tubular transport mechanisms. Very, very important topic. Renal tubular transport mechanisms. So I have few ion channels and movements in the form of animations to show you. So with this, easily you can understand renal tubular transport mechanisms. So in renal tubular transport mechanisms, so let's understand. When fluid flows across the nephron, starting from proximal convoluted tubule, the loop of Henle, the distal convoluted tubule and the collecting duct, what are the different events that happen along the tubule? That is called tubular transport mechanism. So we are going to travel along the tubule starting from PCT to the collecting duct, and we'll see what are the different transport mechanisms. When plasma flows into the glomerulus, it passes through the first portion of the tubule. Which is the first portion of the tubule? PCT, proximal convoluted tubule. If this is one segment of the PCT, let's see what are the changes that are happening here. On the other side, there is blood. This side, which is facing the urine, this is called the apical membrane or the luminal membrane. The other side, which is facing the blood, is called the basolateral membrane. So when blood flows into the glomerulus, it reaches the PCT. What are the changes that are happening here? Reabsorption of 60% sodium, chloride, potassium and water takes place here. So there is reabsorption of 60% sodium, chloride, potassium and water. And what is the mechanism of reabsorption of this 60% sodium, potassium, chloride and water? First, let's see sodium. How is sodium reabsorbed? Through sodium glucose cotransporter, which is called SGLT2, through sodium amino acid cotransporter, through sodium lactate cotransporter, through sodium phosphate cotransporters. So all these are cotransporters through which sodium is reabsorbed. On the other hand, we have exchanger, sodium hydrogen exchanger, through which sodium is reabsorbed and H plus hydrogen is exchanged. Sodium moves inside, hydrogen moves into the lumen. All this collected sodium should move into the blood. On the other side, it moves into the blood through sodium potassium ATPase. This is how 60% sodium is reabsorbed. What about potassium and chloride? How is potassium and chloride reabsorbed? Mainly by paracellular diffusion. In between the cells, you have spaces. They are called paracellular spaces. Through the paracellular spaces, by paracellular diffusion, potassium and chloride is reabsorbed. Water. How is water reabsorbed? Water channels, aquaporin. Aquaporin on this side. On the other side also, aquaporin 1, through which water is reabsorbed. 50% urea is reabsorbed by solvent drag. 50% urea reabsorption by solvent drag. What is solvent drag? Water is the solvent. When water is moving along with water, urea is also dragged. This is called solvent drag. 70% calcium is reabsorbed by proteins called claudin 2. 80% phosphate is reabsorbed. 90% bicarbonate is reabsorbed. Bicarbonate reabsorption is very important because on this side, on the urine side, there are no bicarbonate transporters. There is no direct bicarbonate transporter, but still bicarbonate is reabsorbed. How is that possible? Please listen. When bicarbonate is filtered, it enters into the PCT, combines with H+. When bicarbonate combines with H+, it forms CO2 and water. And this CO2, being a gas, directly diffuses into the cells. And this CO2 inside the cells of PCT combines with H2O water to form H plus and bicarbonate with the help of enzyme carbonic anhydrase. And H plus moves into the urine. Bicarbonate moves into the blood through sodium bicarbonate cotransporter. So you see that even though there are no direct bicarbonate transporter on the urine side, but still bicarbonate has been reabsorbed into the blood. Carbonic anhydrase inhibitors. If you block carbonic anhydrase enzyme, it can act as a diuretic. So carbonic anhydrase inhibitors act as diuretics. How do they act as diuretic? Carbonic anhydrase inhibitors. If you block carbonic anhydrase, you are blocking this H plus. If there is no H plus, sodium cannot be reabsorbed. If you block this H plus, sodium is not reabsorbed. When sodium is not reabsorbed, sodium accumulates in the urine. Sodium is a cation. It will keep pulling anion chloride. Sodium chloride is a salt. Salt will keep pulling water. And all this water comes out in urine. That is called diuresis. So whenever you block the reabsorption of sodium, it can cause diuresis. And that is called carbonic anhydrase inhibitors. Acetazolamide, brinzolamide, all these act as diuretics. 100% glucose, amino acids and proteins are reabsorbed in the PCT. How is glucose reabsorbed in the PCT? Through SGLT2. Look at this, very important. Glucose is reabsorbed by SGLT2 on this side. On the other side, through GLUT2, it moves into the blood. So please understand, SGLT2 is a secondary active transporter, whereas GLUT is a facilitated diffusion. So glucose uses both type of transport. On the urine side, it utilizes SGLT2, and on the basolateral side, it is using GLUT2. So both active and passive transport for glucose. Blocker of SGLT2. What will happen if you block SGLT2? Sodium glucose cotransporter is blocked. Yes, you are blocking glucose absorption. So blood level of glucose comes down. So you can use this for treatment of diabetes mellitus. Yes, SGLT2 blockers, gliflozins, canagliflozin, empagliflozin, tepagliflozin, all these are used in the treatment of diabetes mellitus. You can use them as anti-diabetic drugs. The tonicity of the fluid which leaves the PCT. What is the tonicity of the fluid which leaves the PCT? It is isotonic. Why is it isotonic? See, although so many changes have taken place in the PCT, the most important salts, major salts, sodium, chloride and potassium were 60% reabsorbed. Water is the major solvent. This was also 60% reabsorbed. Since the major salts and major solvent both were equally reabsorbed, proportionately reabsorbed, there is not that much of change in the concentration of the fluid. So even though phosphate, calcium, all that is there, but the major salt is sodium chloride potassium, 60% reabsorbed. Major solvent is water, 60% reabsorbed. Since the major salt and major solvent are equally reabsorbed, there is not that much of change in the concentration of the fluid. That is why the fluid that leaves the PCT is isotonic, because the fluid that entered into the PCT was isotonic. Isotonic means any fluid that has same concentration as your plasma. Plasma concentration is around 300 milliosmoles per liter. The fluid which leaves the PCT is also 300 milliosmoles per liter. It is same because solvents, major solvent, major salts, both were proportionately reabsorbed. That is why there is no that much of change in the concentration of the fluid. It is isotonic. So when you move on to the other segment of the tubule, from the PCT, now the fluid flows into the loop of Henle, the descending limb of loop of Henle. There is one channel in the descending limb of loop of Henle, aquaporin 1. This is a water channel, aquaporin 1, through which water is reabsorbed. So very simple, descending limb, only one function, water reabsorption. How much of water is reabsorbed like this? 15% water reabsorption. this portion is impermeable to salts. So just think, what will be the tonicity of the fluid? Water was reabsorbed, salt was not reabsorbed. If salt is not reabsorbed, salt accumulates in the lumen, making it hypertonic. So the fluid which leaves the descending limb becomes hypertonic. From the PCT, it was isotonic. Now it has become hypertonic. Now the fluid flows into the ascending limb, the thin ascending limb, and then the thick ascending limb. In thin ascending limb, it is only passive reabsorption of salt because hypertonic fluid, highly concentrated fluid has flowed into this portion. So it will be reabsorbed by passive transport because it is already high in the tubule. From high to low, it will go along the gradient by passive transport. So only in the thin ascending limb, you will see passive reabsorption of sodium. From there, it flows into the thick ascending limb. In the thick ascending limb, 25% sodium chloride and potassium is reabsorbed. This portion is impermeable to water. And all three salts, sodium chloride and potassium, are reabsorbed through the same channel, NKCC. NKCC is sodium, potassium, chloride channel, through which sodium is reabsorbed, potassium is reabsorbed, and this potassium is again recycled back into the lumen through ROM-K potassium channels, renal outer medullary potassium channels. Chloride is reabsorbed and chloride moves into the blood through ClC-Kb chloride channel. Blocker of NKCC. If I use a drug to block this channel, I am blocking salt absorption. Whenever you block salt absorption, so this salt accumulates in the lumen. When it moves into the other segments, it keeps attracting water and all this water moves out in urine. That is called diuresis. And that is why NKCC blockers become loop diuretic. What are the loop diuretics? Furosemide. Yes, they are all loop diuretics. What is the tonicity of the fluid which leaves this portion of the tubule? It is hypotonic. Why? Salt was reabsorbed, water was not reabsorbed. It is impermeable to water. So water accumulates in the lumen, making it hypotonic. And that is why thick ascending limb is called diluting segment of the kidney. Remaining 10% bicarbonate reabsorption takes place in this portion. 90% bicarbonate was reabsorbed in the PCT. Remaining 10% is reabsorbed here. What is the disease related to this thick ascending limb? Bartter syndrome. There are 4 types of Bartter syndrome. Bartter type 1 is NKCC mutation, and Bartter type 2, ROM-K mutation. Bartter type 3 is the chloride channel mutation, and Bartter type 4 is Barton mutation. Yes, that was about the renal tubular mechanisms that happened in the PCT, the descending limb, the loop of Henle. Now over to early DCT. 7% sodium chloride reabsorption in the early DCT through sodium chloride channel. So here only we have the effect of first hormone, aldosterone. Very important. Till now we didn't learn about any hormone involvement. Only in the early DCT, aldosterone has its effect. Blocker of thiazide diuretic. Blocker of this sodium chloride channel is called thiazide diuretic. Yes, if I block this channel, sodium chloride, salt reabsorption is affected. If salt reabsorption is affected, it will pull water, water flows out in urine, and that again becomes a diuretic. That is called thiazide diuretics. I have an important event taking place here. PTH and vitamin D dependent calcium reabsorption takes place in this portion. Parathormone and vitamin D dependent calcium reabsorption only in the early DCT. We had calcium reabsorption in PCT also, but that is not dependent on PTH and vitamin D. Only in early DCT, it is dependent on PTH and vitamin D. There's a disease related to this portion. Loss of function mutation of the sodium chloride channel results in Gitelman syndrome. This is called Gitelman syndrome. Over to the collecting tubule. In the collecting tubule, there is a cortical collecting tubule and medullary collecting tubule. Cortical collecting tubule, very important. 4 functions of cortical collecting tubule. It helps in acidification of urine through type A intercalated cell, and this function is done by aldosterone. Second function of cortical collecting tubule, sodium reabsorption through INI-CET channels, epithelial sodium channels. This is also helped by aldosterone. Third function, potassium secretion through Romke potassium channels, which is also helped by aldosterone. The fourth function, water reabsorption through V2 channels. This is helped by ADH. Very important. First 3 functions are because of aldosterone, a different hormone. Aldosterone comes from the adrenal cortex. But the last function is because of ADH, antidiuretic hormone. It is a posterior pituitary hormone. So very important, do not confuse between aldosterone and ADH. Aldosterone, acidification of urine, sodium reabsorption, potassium secretion. And ADH, antidiuretic hormone, helps in water reabsorption. This is the function of cortical collecting tubule. Medullary collecting tubule also, the last function of cortical collecting tubule exactly repeats in the medullary collecting tubule. Medullary collecting tubule, what is that function? Water reabsorption. So the last function of cortical collecting tubule also happens in the medullary collecting tubule. So medullary collecting tubule also helps in water reabsorption. So quickly, through the disorders related to the tubule, Bartter syndrome, Gitelman syndrome, Liddle syndrome. Bartter is in the thick ascending limb, Gitelman in the DCT, and Liddle syndrome in the collecting tubule. If you have confusion, you can arrange this in alphabetical order. B comes first, so that is Bartter syndrome. G comes next, Gitelman syndrome in the DCT, and L comes last. So L is in the Liddle syndrome, gain of function of INI-CET. So in collecting tubules, we have epithelial sodium channels, INI-CET channels. When these channels are over functioning, gain of function of these channels results in Liddle syndrome. Bartter and Gitelman are because of loss of function mutation, but Liddle syndrome is because of gain of function mutation of INI-CET. So what will be the clinical feature of Liddle syndrome? If you have gain of function of INI-CET, it means overactivity of INI-CET. If INI-CET becomes overactive, epithelial sodium channel is overactive. So there is more sodium reabsorption. More you reabsorb sodium, there is hypertension. More the sodium reabsorbed, more potassium will be secreted. So there is hypokalemia. Classical features of Liddle syndrome patient: hypertension, hypokalemia, more sodium reabsorption. This could even result in hypernatremia. So there's more sodium in the blood, less potassium in the blood. Because of more sodium, he goes for hypertension. Hypernatremia, hypertension, and hypokalemia. Classical features of Liddle syndrome patients. So that was about renal tubular transport mechanisms. Let's see if you're able to solve questions from this. This was a repeat question asked from the topic in INI-CET 2022 November paper. Fluid leaving the PCT in the absence of ADH is fluid leaving the proximal convoluted tubule. Yes, isotonic. We did this isotonic because major salts and major solvents are equally reabsorbed. Over to respiratory physiology, the important topic discussions from respiratory physiology. The volumes, lung volumes and capacities, pulmonary function test, flow volume loop and compliance, and also ODC. These are the important topics for discussion in respiratory physiology. So I think let's have a very short break. Maybe 2 minutes we will break. Again, just relax and we will join back after 2 minutes. Just 2 or 3 minutes, we'll just relax and we will join back for respiratory physiology. Thank you. So we're just starting back after a small break. So we just started off with the topics in respiratory physiology. In respiratory physiology, let's start the discussion with the lung volumes and capacities. What are the different lung volumes and capacities and the pulmonary function tests that are done? Very important topic, lung volumes and capacities. This is the static lung volumes and capacities graph. Very important, but it is very difficult to remember the values, and also it is very difficult to remember the definitions for each of these. So I'll teach you one easy method to do this. To start with tidal volume, as I'm telling you, you just breathe this volume of air, then the understanding becomes very simple. Let's do a tidal volume. Now all of you breathe normally. When you breathe normally, 500 ml of air moves inside. This is called tidal volume, 500 ml. When I do inspiration, 500 ml moves inside. When I do expiration also, 500 ml moves out. So tidal volume during inspiration 500 ml, during expiration 500 ml. At the end of tidal volume, let me take a deep inspiration. 500 ml has gone inside. At the end of this tidal volume, if I do a deep inspiration, 2 liter of air moves inside, and this is called inspiratory reserve volume, 2 liters. So what is the formula for inspiratory reserve volume? At the end of tidal volume, by a deep inspiration, how much of air you are able to take inside. This is called inspiratory reserve volume. Expiratory reserve volume. At the end of expiration, at the end of normal tidal volume expiration, how much of air you are able to push out by a deep expiration. If you breathe like that, this comes to around 1 liter. This is called expiratory reserve volume. After doing all this, 1 liter of air still stays back in your lung as a residue. This is called residual volume because inspiratory reserve volume is 2 liter. Expiratory reserve volume is only 1 liter. It means the remaining 1 liter stayed in the lung as a residue. This is called residual volume. Total lung capacity. You add all, you will get total lung capacity. Vital capacity. Vital capacity is of all this, if you leave the one which is not vital for you, which is not vital, residual volume is not vital. You leave the one which is not important, you add all others, this will give you vital capacity. How would you measure all these lung volumes and capacities? When you measure total lung capacity, when you add all this, it comes up to 5 liters. And vital capacity, leaving the residual volume, you add all others, that is vital capacity. This comes to around 3.5 to 4 liters. If you want to measure all this, you use this technique called spirometry. By using a spirometry, it's a machine which you put into the tube. A tube is put into the mouth and you breathe into the tube. When you breathe into the tube, the monitor will draw the curve for you. But the problem here is a spirometry cannot be used to measure a residual volume because residual volume is not moving out at all. It is staying in the lung as a residue. Only if you breathe into the spirometer tube, you can measure this. If you don't breathe into the spirometer tube, you cannot measure residual volume. So that is why a spirometry cannot measure residual volume. If you cannot measure residual volume, you cannot measure total lung capacity. If you cannot measure total lung capacity, you cannot measure FRC because FRC, functional residual capacity, is ERV plus residual volume. This is FRC. When you add this both, expiratory reserve volume and residual volume, this will give me FRC. So if you cannot measure residual volume, you can't measure TLC and also FRC. So if you want to measure all this, you use techniques where you use gases which will go into the residual volume and they will come back. What are the gases? Nitrogen washout method, helium dilution method, because nitrogen and helium, they can go into your residual volume and they can come back. So for measuring residual volume, total lung capacity and FRC, we use nitrogen washout method, helium dilution technique, and also we can use Body plethysmography. It is an instrument. It's a box-like instrument. You go sit inside the box and you breathe into the box. It will keep measuring the volumes and pressures inside the box. So that is called body plethysmography technique. The dynamic lung volumes and capacities. Let's learn about FEV1, FVC and the ratio of FEV1 to FVC. FEV1 means forced expiratory volume in the first second. FVC is forced vital capacity. FEV1 by FVC, ratio of FEV1 by FVC, this is called Tiffin index. Tiffin index. What is the use of measuring this Tiffin index? I'll just write Tiffin index. Tiffin index is FEV1 divided by FVC. The normal Tiffin index 83%, because a normal person, look at the normal graph. In a normal person, when you measure volumes and time, normal FVC is 4 liter. Yes, normal vital capacity is 4 liter. Out of this 4 liter, when you do a 4 liter vital capacity, how will you do a forced vital capacity? You ask the patient to take a deep inspiration and then you do a forced expiration. It will take at least 3 seconds for the patient to do this. So the 4 liter is going to move out in 3 seconds. But out of this 4 liter, how much actually moved out in the first second? 3.3 liter. So FVC is 4 liter. How much came out in the first second FEV1? 3.3 liter. You take a ratio of FEV1 by FVC. This will give you 83%. 3.3 by 4 is 83%. It means a normal person, out of the 4 liters, he can push out 3.3 liter, 83% in the first second itself. But if you have obstructive or restrictive disease, the value is not the same. FVC is 2 liter in both obstructive and restrictive disease, because when you have any type of lung disease, be it obstructive or restrictive, FVC can't be 4 liter. It is only 2 liter. So FVC falls to 2 liter. So a respiratory diseased person cannot push out 4 liter, only 2 liter. Out of this 2 liter, in an obstructive disease patient, when you have any obstruction to the flow, any obstruction, any inflammation or anything is obstructing, expiration becomes more difficult. So usually in obstructive diseases, to cross the obstruction and to push out the air, it is very difficult. So expiration becomes more difficult. If expiration is more difficult, out of the 2 liter, this person cannot push out 83%. He can only push out 50% because expiration becomes difficult because of the obstruction. So out of the 2 liter, he is pushing out only 1 liter. 1 by 2 is 50%. So Tiffin index has fallen from 83 to 50% in obstructive disease. What happens to the index in restrictive disease? In restrictive disease, FVC is 2 liter. When you have any restriction, fibrosis or any scar tissue or obesity, any kind of restriction in your lung tissue, the lung is not expanding. If lung is not expanding, you can't do inspiration properly. So restrictive diseases are difficulty in inspiration, not expiration. Obstructive disease, you have difficulty in expiration, but restrictive disease, you have difficulty in inspiration. When you have difficulty in inspiration, out of this 2 liter, inspiration is difficult, but expiration is okay, easier only. Expiration is not affected in restrictive disease. So out of this 2 liter, almost 1.8 liter he is able to push out in the first second, because his expiration is not affected, only inspiration is affected. Since expiration is not affected in restrictive disease, out of the 2 liter, almost 1.8 liter he is pushing out in the first second. Now you take a ratio, 1.8 by 2 is 90%. So Tiffin index increases to 90% in restrictive disease. So this index can be used to differentiate between obstructive diseases and restrictive diseases, the Tiffin index. Over to the flow volume loop. This is also one of the pulmonary function tests with flow in liters per second on y-axis and volume in liters on x-axis, the flow volume loop. So in the flow volume loop, This black colored loop that you see, this is the normal one. When you read this flow volume loop, you ask the patient, it's a peak flow meter, you put it into the mouth, you ask the patient to take a deep inspiration, the curve goes down like this, inspiratory curve. Then he'll do an expiration, the curve goes up like this, inspiratory curve and expiratory curve. The black one is the normal curve. And this part of the curve, which is outside the loop, this is called the residual volume. Yes, because residual volume is a volume which is not moving out at all. So whichever part is outside the loop becomes residual volume, because it is, you are not breathing it out. It cannot come into the loop. So this portion which is outside the loop of this black curve becomes the normal residual volume. This is the normal curve. And this curve can be shifted to the right or it can be shifted to the left. This curve is shifted to the right. The blue curve is the right shift of this curve. R for right shift and R for restrictive lung disease. So in restrictive lung disease, the curve shifts to the right side. R for right shift, R for restrictive disease. And in restrictive disease, there is a decrease in the residual volume. The black one, which is outside the loop, this is residual volume normally. Outside the blue loop is the residual volume for the right shift. So did you notice that residual volume has decreased? Yes. Why residual volume has decreased? R for reduced residual volume. Why residual volume has decreased? See, this is because in inspiration, restrictive diseases, there is more problem with inspiration. So the lung is not expanding properly. There is a restriction. Take fibrosis. Because of the scar tissue, lung is not expanding properly. When there is any restriction and lung is not expanding properly, you can't take in enough air. When you don't take enough air, when your inspiration itself is less, the volume that goes into the residual volume also will be less. So that is why reduced residual volume. So right shift, R for restrictive disease, R for reduced residual volume. The green curve, exactly opposite. This belongs to the left shift, obstructive disease. In obstructive diseases, there is increased residual volume. Right shift and left shift. There is a pink curve where you can see both inspiration and expiration are affected. This purple curve or the pink curve, this is seen in fixed airway obstruction. When you have a fixed airway obstruction like a tumor or a foreign body which is locked inside, in fixed airway obstruction, both inspiration and expiration becomes difficult. So the curve becomes small like this. This is fixed airway obstruction. And one special feature for obstructive disease curve is the green curve. Look at the green curve. You can see this scooping effect in the green curve. The curve scoops during the expiratory part. Why does the curve scoop during the expiratory part like this? It is called the scooping effect. The reason for scooping effect is if there is any obstruction in obstructive diseases, the patient has to breathe against this obstruction. He has to do expiration against the obstruction. So he will put more effort. So that effort part of the breathing, he is putting lot of effort. So the curve goes like this. This is called the scooping effect. Very typical for obstructive curve. At which volume or capacity pressure measured at the upper airway becomes 0? Yes, INI-CET 23 question. When you say the pressure measured at the upper airway becomes 0, it means lung is in the relaxed state, which is called the relaxation volume, FRC. Functional residual capacity is called relaxation volume because at the end of expiration, it is called FRC. At the end of expiration, if you do an expiration, the lung is in the relaxed state. It means the pressure maintained becomes 0. So that is why FRC is called the relaxation volume of the lung. So the answer to the question is FRC, relaxation volume of the lung. So over to lung compliance. The compliance curve. What is the meaning of compliance? Compliance means change in volume for the change in pressure. This is called compliance. If I apply a particular pressure, what is the change in the volume? So look at this balloon. I'll show you lung compliance. I'm going to apply a particular pressure. Look at the change in volume of this lung. When I apply this much of pressure, there is a change in the volume in this lung. This is called compliance. Change in volume for the change in pressure that I applied. So this lung is this much compliant. That's why its volume is changing by this much. That is why in the curve for compliance, we have volume on y-axis and pressure on x-axis. Let's take any pressure value, 10 centimeter of water. For this much of change in pressure, how much is the change in volume? Normally, it is around 4.5 liters. So this is a normal curve. The black one is a normal curve. In fibrosed lung, if the lung has gone for fibrosis means scar tissue. A fibrous lung cannot expand. So if you apply the same pressure, the change in volume is only 2 liter. It is not 4 liter. Only this much is the change in volume. So in a normal curve, I'll just mark the normal compliance. For 10 centimeter change in water, this much is the change in volume. But in fibrosis, for the same change in pressure, the change in volume is less because the lung is fibrosed. It can't expand. So compliance decreases in fibrosis. But in emphysema, what is emphysema? This is a condition where all the individual walls are all damaged. The septa, the alveolar walls are damaged. So all of them join to form a big bag which can expand very well. So in emphysema, compliance increases. So when I apply the same pressure, the change in volume is this much. It has increased. So compliance has increased. So in fibrosis, compliance decreases, and in emphysema, compliance increases. The normal value of compliance is 200 ml per centimeter of water. Over to ODC curve, the last topic in respiratory physiology, oxygen hemoglobin dissociation curve. This is the normal oxygen hemoglobin dissociation curve with partial pressure of oxygen on x-axis and percentage oxygen saturation of hemoglobin on y-axis. It means hemoglobin is how much bound to oxygen, that is on y-axis. At a normal partial pressure, what is a normal partial pressure in your arterial blood? 100 millimeter of mercury. When partial pressure is 100, when you mark this to the saturation, you will see that almost saturation is 100, almost 100. So when your partial pressure of oxygen is 100, almost saturation is also nearly 100. It is never 100, little less than 100. So partial pressure of oxygen is 100. Hemoglobin is 97.5% saturated with oxygen. This is a normal value. When your partial pressure of oxygen is 100, hemoglobin is 97.5% saturated with oxygen. If this value falls from 100 to 60, when your partial pressure falls from 100 to 60, look at the saturation. Saturation falls to 90. It means hemoglobin is 90% saturated with oxygen. A further fall from 60 to 27 millimeter of mercury. When PO2 falls to 27, saturation falls to 50%. So hemoglobin is 50% saturated with oxygen. And that is why this P27 is called P50 value. So what is P50? The partial pressure at which hemoglobin is 50% saturated with oxygen. That is called P50 value. And 60 millimeter of mercury, this is called safety factor. Why it's called safety factor? Even if your PO2 falls to 60%, body is able to maintain 90% saturation. That's why it is called safety factor. This is the normal curve. This curve can be shifted to the right like this. This is called right shift of the curve, or it can be shifted to the left like this. This is called the left shift of the curve. What are the causes for right shift of the curve? R for right shift, R for release of oxygen to tissue. Whenever there is a need to release oxygen to the tissue, curve shifts to the right side. When will you have a need to shift oxygen to the tissue? When the tissue is suffering without oxygen. When the tissues are suffering without oxygen, this is called hypoxia. So in hypoxia, there is a right shift of the curve. Or anemia. Or exercise. When you do exercise, the exercising muscle needs more oxygen. So in hypoxia, anemia and exercise, there is a need to release oxygen to the tissue. So the curve shifts to the right side. What are the other causes for right shift of the curve? Right means something good, something positive. So let's put all positive factors. Increase in H+, increase in CO2, increase in temperature, and increase in 2,3 BPG. Let's put all increasing factors. All this will cause right shift of the curve. What are the factors which will increase 2,3 BPG? 2,3 BPG can be increased by growth hormone, thyroid hormones, androgens, sex hormones. Growth hormones, thyroid hormones and androgens cause right shift of the curve by increasing 2,3 BPG. And right shift is called as Bohr effect. See, R for right shift, R for release of oxygen to tissue, R for Bohr effect. What about left shift of the curve? This is left shift of the curve. Left for tissue, left without oxygen. When will the tissue be left without oxygen? Left without oxygen when hemoglobin is holding all the oxygen. When hemoglobin oxygen affinity increases, hemoglobin will hold all the oxygen. It is not releasing to the tissue. So tissue is left without oxygen. So in left shift of the curve, hemoglobin oxygen affinity is more. What are the causes? Left means something negative. So we'll place all negative factors. Decrease in H+, decrease in CO2, decrease in temperature, and decrease in 2,3 BPG. All this causes left shift of the curve. So these are the causes for left shift of the curve, and few other causes for left shift of the curve. Fetal hemoglobin, because it has gamma chains. Stored blood. When you store blood for a long time, because when you store blood, glycolysis decreases, 2,3 BPG decreases, so it can cause left shift of the curve. And this left shift is called as Haldane effect. L for Haldane effect, R for Bohr effect, L for Haldane effect. And there is a double Bohr effect. What is double Bohr effect? This happens at the level of placenta. If this is the placenta, placenta has two sides, the fetal side of placenta and the mother side of placenta. How does the fetus breathe? Fetus will breathe CO2 into the mother. So on the mother side, CO2 increases because mother is receiving CO2. But on the fetal side, CO2 decreases because fetus is breathing CO2 into the mother. So on the mother side, when CO2 increases, this causes right shift of the curve. And on the fetal side, when CO2 decreases, this causes left shift of the curve. So right shift and left shift of the curve. On the mother side, right shift, fetal side, left shift. Placenta is one single organ, but on both the sides, it is having two different shifts. This is called double Bohr effect, which happens only at the level of placenta. INI-CET November 2022 question. The below graph showing oxygen dissociation curve, the curve marked A. If you look at these curves, they are all sigmoid shaped curves. Normally, oxygen will produce a sigmoid shaped curve. Oxygen hemoglobin curve is a sigmoid shaped curve. But the oxygen myoglobin curve will give you a rectangular one like this. So the curve A belongs to myoglobin, because the special thing about myoglobin is hemoglobin has 4 heme, so it can attach to 4 molecules of oxygen. But myoglobin has 1 heme, which can attach only to 1 molecule of oxygen. But although it can bind only to 1 molecule of oxygen, the affinity is much higher. Because of these reasons, myoglobin produces a rectangular curve, whereas hemoglobin will produce a sigmoid shaped curve. Yes, with that, we come to the end of our session. So I think most of the important topics we have covered here, and most of the repeat questions also I have covered in this portion. So all the portions that we have discovered are very high yield topics along with the PYQs. So one mantra again I can tell you is revise, revise and revise. Revise the topic again and again. And the other thing is PYQs. Keep solving as many number of questions as possible, and please try to solve all the PYQs before you go for your exam. My best wishes to all of you to come out with flying colors after your exam. Lot of people work hard, but only successful people know how to work hard at right things. So don't waste your time. You have very little time for your exam. Work hard at the right thing. And more important, study what is important for your exam. Don't waste time reading unimportant things. Common things are more commonly asked. Please give more important for high yield repeat topics.